In another 3 minutes, we'll start off. Huh, Vasant?
Okay, ma'am.
So good evening, everybody. How many people have joined? There are 19 people who have joined. Some of what we say now may not make much sense, but you will understand a lot of it in the workshops because it will again be repeated and repeated. And there will be a lot of interactions. So no more didactic lectures. It'll just be interactions in groups. So you learn a lot. Shall we start, Vasant?
Yes, ma'am. I'm okay, ma'am.
Okay. So good evening, everybody. Thanks for joining. Thanks for the learning yesterday. So Dr. Vasant is my colleague at Apollo Hospitals, Chennai. He is what you call the young batsman. And there is a joke, Rajnikant jokes are very famous. So Vasant and Rajnikant were traveling in the flight together, and they happened to be sitting in the front seat together, adjacent. And everybody was coming and asking Rajnikant, who is this with you? So over to you, Vasant. Yeah, and I'm sure you'll do great batting even now. Over to you.
Thank you, ma'am. Thank you, ma'am. Happy to meet you all in this ECMO meeting now, and we'll be discussing about CRRT and ECMO. So, since you'll all be part of this Chennai workshop, I thought I'll introduce you to two superstars. The two superstars are first ECMO and CRRT. The other superstars in this image are Rajnikant and Kamal Haasan, you may all be knowing. So I want the session to be interactive. I'll be asking questions. So please unmute yourself and answer. So the first question is, among the two superstars here, which one is ECMO and which one is CRRT, in your opinion? I want answers. Then only we'll move forward. Okay?
Put to the chat box if you can.
Yeah.
I'm sure everybody knows Kamal and Rajni.
So if you ask this basic question, answer this basic questions, then we'll move to the advanced level.
Somebody has to at least save the group.
Can you repeat the question?
Okay. Which one is CRRT and which one is ECMO? Rajnikant is CRRT or ECMO? Okay, no answers. So I think the audience are confused. They want both to perform both roles. So
they don't want to hurt. They don't want to hurt fans of either Rajni or Kamal.
Okay,
Somebody has said Rajnikant should be ECMO. There
oh,
you
we have Dhanush also. We have Dhanush in the group.
Rajni
no, Dhanush is also there. Okay, nice.
Yeah, we have Dhanush also competing. Okay.
Yeah. Okay. Nice. Pratima ma'am says okay. There are a lot of Kamal for ECMO, Kamal for ECMO. Everyone wants 2 for Kamal Hassan votes. Okay, thank you guys. So we'll move on. So this is a typical patient of. So before I start off, my presentation is a remake version of Indra ma'am's presentation, which she had done few years back. So I modified it. So thanks to Indra ma'am for this. And so this is a typical patient of ECMO. You have this ECMO circuit here, the machine here, console, and the CRRT machine also lying along. So we'll be discussing how do we go about RRT options in ECMO, and do they really need it or not. So to start off, so I'll start with the scenario. I'll be discussing only about pediatric cases. Like the principles are the same if it's a pediatric or adult patient, so it doesn't really matter. So you have a 4-year-old with severe ARDS who has metapneumovirus pneumonia, like and severe ARDS. On day 5, you initiate the child on VV ECMO in view of refractory hypoxia. So you initiate on VV because the heart is normal, the other organ functions are all normal. So basically it is a single organ injury and there are no as such contraindications for ECMO. So you go ahead with VV ECMO, and after initiating ECMO, you find that the ECMO surgeon tells you, just watch out for the urine, man. Why is the surgeon worried about urine output? When you just like that, you just started ECMO, but he's immediately saying you watch out for the urine output, man. What can be the reason? So remember, ECMO is giving only rest to your heart and the lungs. The perfusion overall improves to the body parts, but your kidney has to do extra work. It causes little bit of additional strain on your kidney. That you'll have to remember. But kidney has a very huge heart. Like for Tamilians, you will all know this Vadivelu dialogue, no? Evlo adichalum tangaran. So it's like that. Ivlo nalavana. So kidney is like that only. Okay, he can tolerate how much ever hit you give him. Okay, but once the hit happens, no, it is very, very dangerous. So the AKI will not occur so early, but once the AKI occurs, it is like quite detrimental. So they say that to equate it, they say AKI is 100 times more dangerous than an MRSA infection. And the incidence of AKI on ECMO is close to 70%. That means 7 out of 10 patients on ECMO will land up having AKI. So just remember that. And on ECMO, the need for RRT is like 50%. So 50% of your patients are ultimately going to need RRT. And this is aggravated by factors like additional hits, like sepsis, you give an additional antibiotics, nephrotoxic drugs, and shock if it is there. Okay. So how do you identify early kidney injury? Because we all know that urea creatinine is going to take some time. Creatinine generally rises after 48 hours. So early predictors is commonly used, like not very commonly, but some units tend to use this index called renal angina index. So it takes into some risk factors, like your sepsis or ICU admission will give a score of 1. Suppose you have a ventilated patient on inotropes, so that gets a score of 5. And you can use one of your AKI staging criteria. Suppose the patient's fluid overload is 7%. Okay, so patient is on ventilator and inotropes, so the score becomes 5, and the fluid overload percentage is 7%. So which means the score is 2. So 5 into 2 will become 10, no? So score of more than 8 means it is bad. That means this patient is going to be at risk of AKI. So don't wait for your urea creatinine to identify early AKI. So this is the concept of renal angina index. Basically, using renal angina index, you can predict the future occurrence of AKI. So as I already discussed earlier, creatinine has a lot of fallacies. The basic thing which many of you will know. So creatinine to rise, it takes more than 48 hours for it to rise, and it's affected by nutritional status of children and other factors. So that's why we rely on biomarkers like NGAL. Though not available in many centers, most of them won't be doing, but it probably may be the future. Okay. So in this slide, if you see what happens when there is AKI on ECMO. Okay. So this is the Kaplan-Meier survival analysis. If you see, for any patient without AKI on ECMO, the survival rate is 80%. So no AKI, survival is 80%. AKI is stage 1. Survival becomes 60%. So like 20%, it keeps dropping. So stage 2, it becomes 40%. On stage 3, if you have a stage 3 AKI on ECMO for whatever indication, the survival drops down to 20%. So this is one study which has shown this. So that is the impact of AKI on ECMO. So it is independent predictor of very bad outcome. So how does AKI develop on ECMO? If you see, one is earlier the child was like hypoperfused, so there is ischemia. Once you reperfuse the organ, there is likely to get injured again. So this is called ischemia reperfusion injury. And suppose you do VECMO, that will have sometimes a non-pulsated flow that can again affect the kidney. So that you have to remember. And ECMO is all extracorporeal, so it runs through a pump. So blood flowing through the pump can cause hemolysis. So that is another reason for AKI. And in addition to it, other factors which can cause AKI are SIRS, because any extracorporeal therapy will trigger systemic inflammatory response syndrome that can again worsen AKI. In addition to it, you'll have your usual reasons like nephrotoxic drugs, sepsis, other things. Okay, so that's why AKI can develop on patients on ECMO. So that's why the surgeon was worried. So because of like every 7 out of 10 patients on ECMO can develop AKI. So urine output for usually for any ECMO patients, you don't want them to be on too much fluid overload status. So you just start on Lasix infusion. And for lungs also, you want ARDS, no? So you want them to diurese well. You start on Lasix infusion. The patient's urine output is 1.8 ml per kg per hour. Urea creatinine is 38 and 0.5 for a 4-year-old child. Bicarb is 21. Potassium is 4.3. Input is 1650. Output is 500 ml. The positive balance is 1150. Fluid overload percentage is 48%. Weight is 14 kg. So what will you do now? Is there any need to start RRT now, or we can wait and continue Lasix infusion, or what is your opinion? Anyone wants to answer? Lasix may, Dr. Kushbu has said, Lasix may cause tubular damage itself and worsen AKI. Very rightly said. So can we start RRT now? So what I'm trying to say is, see here, if you see the urea creatinine is normal. So generally, in such situations, what you have to do is, early RRT sometimes is beneficial. Dr. Pratima madam has replied saying early RRT is beneficial. So early RRT is beneficial, but what is the indication for that is what we are going to discuss now. So whenever you put on ECMO, the immediate thought in your mind should be like, you should be eagerly waiting to initiate RRT. Not saying just put RRT, but you should eagerly waiting for the indications. Whenever it happens at the earliest, you'll have to probably start. So that you'll have to keep in mind. So keep a lower threshold. ECMO means the patient is going to become edematous. Okay, generally, not always, but just keep that in mind. So if the patient is becoming fluid overloaded, so that is the right time to initiate. So you don't wait for AKI. You don't wait for metabolic acidosis alone. You don't wait for electrolyte disturbances. You generally expect a combination of indications in initiation of RRT. But in ECMO, you want to initiate RRT when the patient has fluid overload alone. Here, the patient's fluid overload is 8%. It can easily become 10%. So this is probably the ideal time to initiate RRT. Some institutes even go to an extreme level of initiating RRT to prevent fluid overload. So that is probably our goal, like in future. For now, at least when the patient develops fluid overload, we can at least start early RRT rather than waiting for AKI. So the message here is, don't wait for AKI to set in. Initiate RRT early at the time of fluid overload. So fluid balance and outcome, if you see, they've identified that the positive fluid balance on day 3 is an independent predictor of 90-day mortality. So that's why we are saying initiate RRT during positive fluid balance. So Why do you want to do renal replacement therapy on ECMO? So one is you can manage the fluid balance better, and you are going to decrease the chances of fluid overload. As Dr. Kushbu rightly said, it will decrease the further insult to your kidney by decreasing your Lasix usage. And you can manage your nutrition better. The ECMO therapy, you don't know how long it is going to be. So when you're able to get good establishment of fluid control, you can utilize that good fluid balance by introducing more nutritional support. So you can go up on full feeds and you can manage accordingly. Okay, you need not worry about the protein overload, etc. in a patient on AKA. And sometimes it can help you in removing the inflammatory mediators also, especially if the patient's underlying reason is like sepsis or so, that will be helpful partly. And electrolyte abnormalities, acidosis can get corrected. So what form of RRT will you decide? Can you do IHD, SLED, PD, or CRRT? Any choices and why? It's actually a simple question. So what modality of RRT is? ECMO is a continuous form of therapy. So obviously we'll prefer one option which is continuous, which runs 24 hours, just like your native kidney. So CRRT is better, right? Well said. So why do you prefer CRRT? Because obviously it is basically CRRT resembles your native kidney. So which works 24 hours. So this will also work 24 hours. It is steady. It is very gentle on the fluid removal and solute clearance. And because it works for a longer duration, solute clearance and other things are better. And it does not rush. It maintains a stable hemodynamic. If you do CRRT or, IHD or SLED, you will be in a situation where there is hypotension, hypertension. So all those things are, which are detrimental. So you don't want such things, which may affect your ECMO flows also. So you prefer something which is stable, which does not affect your hemodynamics, and has very advantages like cytokines can be removed. And any fluctuation, there is a risk of cerebral edema. So that doesn't happen here. And IHD is notorious for sometimes causing osmotic disequilibrium. So the chances are much, much lesser if you do CRRT. Okay. Another thing, disconnection can happen if you do any intermittent form of therapy. Any handling is going to cure the risk of infection. So you don't want that to happen. Okay. So there's something called inline hemofilter versus a CRRT device. So has anyone used this inline hemofilter? Yes, no, you can even raise your hand. That will be enough. So this is generally used in this cardiac units. So where they just want to do fluid removal. So that is like similar to the connections, everything people have said no. Pratima madam has said no. Okay, so this is sometimes used just for if you want to do only fluid removal. So then they sometimes tend to use this hemofilter. The connections, everything are same. It is just that it does only one work, which is just removing the fluid. And it is in cardiac units, they generally do it along with the bypass circuit. So you can use it with this also, but traditionally it is done with a bypass circuit. So here you can see in the hemofilter, no? So I'll just to explain here, this is the venous drainage cannula. This is the CPB, I said no, bypass thing. So it has a bladder sort of thing. Then after that you go into the pump, then you go into the oxygenator. So here you see something called a filter. This filter, the fluid removal will happen with the help of an infusion pump. So the removal here, and it's connected to a effluent, which is via Euro bag or something, you will sort of collect the fluid, which is drained. Okay. So this is infusion pump regulated. So the problem with this is it is pump controlled and there is no metabolic control at all. So unlike ECMO, no, you will have solute clearance, sodium, potassium, electrolytes, acidosis, all those will get corrected. Here that doesn't happen. Or CRRT, everything happens. So it is only fluid removal. If you want just isolated fluid removal, you can do this. And the biggest problem is the duration is like quite short. It works generally for 6 to 8 hours only. And as with any infusion pump, the exact effluent amount you may not be, you will set it at 50 ml per hour, but not always it will come out as 50 ml per hour. There may be some value change. It may be little smaller, for lesser amount, 45 or 40 ml. But in CRRT, that fluid control also is a little better. And both of them will need systemic anticoagulation. So the same child, you have initiated RRT as a CRRT method for fluid overload because the patient was fluid overload close to 8.5%. And you decide to initiate on CRRT, highlighting whatever reasons I said. So many benefits are there. So you decide on CRRT. So how do you initiate CRRT? Do we need to get a separate access for CRRT and run the CRRT mission separately? Or can we do the CRRT along with ECMO? What's your opinion, people? Separate access or do it along with ECMO? If you have luxury, always separate. Okay. Both are possible. Okay. So in our unit, we sort of do it along with ECMO for the very simple reason that most of the children, it is not possible to get access separately because for a CRRT also you need bigger French cannula. See, you can imagine, no, your patient, suppose this is a 14 kg child, you've already utilized for your ECMO, it will be like femoral and IJV. So 2 lines have gone. And you will have one more access probably in the other femoral for maybe as a central line. Then you'll also have a arterial line. If it is going to be another separate access, it will be again IJV. So you'll have all the lines occupied. So it sometimes can be a little challenging. And getting access for small children with bigger French cannula can be problematic. And you don't know how long the ECMO is going to run. So usually central lines also we tend to change after 5 to 7 days because of risk of infection. So all those factors are there. So probably you will prefer to do it along with an ECMO circuit itself. I'll tell you how it can be done. And we have never done it separately. So some units will do it, but I think it will be preferable if you do it along with the ECMO circuit. So first is access along with the same, no need to take a separate access. And I mentioned something called what will be a target. You will target tea or coffee. So what do I mean by tea or coffee in this regard with respect to CRRT? So this is an analogy. Anyone has any idea? Okay. So basically this is, okay, before I go into that. So how does it work? There's something called diffusion and convection. So diffusion is removal of small molecules like urea and creatinine. It is something similar to a tea bag. Okay, your particles sort of diffuse out easily, when you insert the tea bag into the water. So if you want diffusion as a process, you use the tea bag concept. When you have convection, like that is solvent drag. When you use your coffee particles and over the filter, you just pour water. Along with the water, the coffee particles also sort of get removed. So that is called convection, which uses a principle called solvent drag. Okay. So that will help you in removal of larger molecules and maybe some amount of cytokines. So in sick children, we generally sort of, and plus fluid removal is convection also. We sort of want everything most of the time, no? We'll want both diffusion and convection together most of the time. So that's why the principle usually will be CVV, HDF. That'll be your preferred mode. And type of filter will depend on age of the patient. So it's basically based on body surface area, no? So accordingly, you'll select what type of filter you want. And anticoagulation is universal. Generally, if your ECMO patient is on heparin, the same heparin is probably enough for your CRRT also. And priming, generally, the volume of CRRT is like much lesser compared to ECMO. So even saline priming will do. Okay. So this is your prescription of CRRT on ECMO. So if you compare ECMO and CRRT, suppose for a 14 kg child, the blood flow rate is 100 ml per kg, usually approximately. So it will come to 1400 ml. Okay. So CRRT blood flow usually, which you said is, set rate is 5 ml per kg, which is 70 ml. So you can imagine it is 20 times lesser than the ECMO flow. So 1400 ml of ECMO blood which is flowing through that circuit, if additional 70 ml flows through the CRRT, it is not going to cause much of any hemodynamic instability or something. It is just 1/20th of the entire ECMO flow. Okay. So this will be your approximate settings and all. Okay. Pre-membrane, post-membrane pressure, this is it. And for CRRT, you will have something like this. So dialysate flow rate, replacement flow rate, effluent dose. If you add this divided by your weight, it will come to around 28 to 30 ml per kg. Okay, if you can keep additional fluid removal if you want. So this will be something like your CRRT prescription for this patient. Okay. Any doubts in this? Okay. So as I said, for priming, even saline will be doable. If you can, no need for separate blood priming and all, because the extracorporeal volume is just another 1/20th of the entire flow. Okay. And the ECMO pressures are much higher than the CRRT pressures. That pressure difference you have to keep in mind. And as I said, we prefer to do CVV HDF as a mode of filtration, which does both diffusion and convection, because we want both fluid removal and solute clearance to happen simultaneously. Same patient you have initiated now. The child is maintaining good ECMO flows, is maintaining your oxygen targets. ACTs initially were stable, 151 and 154 on heparin. But now after ECMO CRRT initiation, the ACTs have been like little on the lower trend. So your target was somewhere between 150 to 170. Now it's going to like 132, 129. And despite increasing your heparin to like 30 units per kg, which is sort of like nearly maximum you can sort of assume. Okay, so the new perfusionist is coming, is worried. So what is the reason behind it? Why is he worried first? And what can be the reason for this increasing dose requirement of heparin? Okay. So basically, see, you have added another additional connections to the ECMO circuit. So the perfusionist is worried because there is an increased risk of clotting. So it is a simple answer. So why does this increased risk of clotting happens? Because of the additional connections, small connections, multiple connections are there. So that happens. But why is the ACT levels dropping down just after initiating CRRT? So that's because usually your heparin is cleared by your kidney. So when there is AKA or something, it is not that well cleared. So once CRRT, it is a like efficient method, no? So the heparin is also cleared well by your CRRT circuit. So the ACT level drops down and your heparin requirement goes up. So that is the reason behind this. So risk of clotting is generally higher. You're supposed to measure look for the clot by using a torch as shown in this image. Okay. And more you do fluid removal, the risk of clotting is higher because the blood is going to get thicker and thicker, no? So the risk of clotting is going to be higher. And just like you do for CRRT, you can reduce the CRRT clotting risk by doing the replacement fluid pre-filter. And if you don't need, you can sort of come down on your solute clearance rate also. Okay. And on RRT, your heparin dose will go up. That you have to keep in mind. Okay. An additional complication which can sometimes develop is risk of hemolysis, as I already mentioned. So how do you identify hemolysis? Simple, peripheral smear, LDH. But you can even use your blood gas to identify hemolysis earlier, which we have found out. That's something called carboxyhemoglobin. Here you can see it's 4.8%. Okay. If carboxyhemoglobin levels are rising, so that is an important indicator that your patient is probably going into hemolysis, because you don't have this, what do you call this, haptoglobin or something, plasma hemoglobin, that is not available in all centers. Very few centers only have it. So you can rely on this ABG, which has coaximetry. Okay. Not all blood gas machines will have this. The blood gas machine should have this coaximetry value, which has this carboxyhemoglobin. So you'll have to look for it. And if it is high, then you probably can suspect hemolysis in your patient. So where do you connect the CRRT circuit on ECMO? Okay. So for this, you'll have to have a understanding of the pressures. See, this is your venous side. So venous cannula draining, it goes into the pump. The pump, centrifugal pump, from there the pressure, it is pulling, no? First it pulls. After that, it goes into the positive side, then membrane, then it goes back to the patient. So anything before the pump is a negative pressure, and anything after the pump is your positive pressure. So always remember, the rule is to start from positive to negative. Okay. So you can, so all these places you will have three ways. Three-way will be here, three-way will be here, three-way will be here. So you can either take from post-pump and give pre-pump, or post-membrane. Oxygenator is called membrane. So post-membrane to pre-membrane, you can do it, or post-membrane to pre-pump. Okay, we generally do it post-membrane to pre-pump. Okay, this is what we do. Okay, this is principle number one. You should never go the reverse, negative to positive. Okay, that should never happen. You always go from, because the gradient is from, always for a flow to happen, it should be from positive to negative, no? So you go from this side to this side. Second reason is, you should never go post-oxygenator as written. You don't take from here, even this is positive also, post-pump or pre-membrane. You don't take from here and return post-membrane. Anything you return post-membrane, here who is sitting? Patient is here. Okay, by mistake, by some chance, new perfusionist, someone, or due to whatever reason, some air enters here, it will directly go into the patient. So that is very, very high risk, and patient can collapse all of a sudden. All these spots, no, like pump, this membrane and all has like places where you can remove the air. Suppose if air enters accidentally, you have a slot where you can sort of remove the air. You'll have alarms also in it to identify presence of air in it. Okay, these are all safety mechanisms. So basic guide, high pressure to low pressure, never return post-oxygenator, and ensure all these connections are handled by perfusionists alone. So better, like only one person who knows it properly has to handle it. Okay. So basically all these are tough processes. You can't have you have to have a dedicated, you can't have a nurse who does both work. So it can be challenging. So you prefer to have one person who runs this separately, CRIT technician, okay, or a perfusionist who knows this. So where to connect, we have already discussed. You can access from anywhere from the positive area, but never return post-oxygenator, okay, because risk of air embolism and sudden collapse. So this similar connection only, this is a hemofilter figure. Here you can see access is post-oxygenator, return is pre-oxygenator. So different places where to access and return is being shown. This is post-pump and pre-pump, okay. So here, this patient, we are taking it from the post-oxygenator, returning pre-pump. This is what we do in our hospital. So coming to the pressure differences, if you see, normal patient on CRIT, your vein is an IJV, no? Your access catheter is an IJV. So usually it is going to suck blood. So its access pressures are generally negative, okay. But here your CRRT, suppose I'm connecting it to the post-oxygenator, so it is all positive pressure, no? So you can see the access pressure is positive. It is +8, +10, it will be like that, okay. So this pressure differences you have to keep in mind. So when you do this, no, there is a chance that the CRRT machine can have alarms, okay. So you're supposed to, you can adjust the alarm settings, basically. Access alarms, you have a range from -250 to +200. So kindly adjust these settings. Return alarms also are there, -50 to +350. So these alarm changes you'll have to sort of adjust, because or else you'll have repeatedly this alarm coming up often. So that you'll have to keep in mind. So you can, coming to the end of the presentation, you can do other things also. It doesn't mean that you can't prone a patient on ECMO. You don't, like, even if the patient is on CRRT, still you can prone the patient on ECMO plus CRRT. And a lot of connections. So many things are there, no? So there is risk of infection. So beware of that. And antibiotic dosing, always remember, just like I said, no, heparin dose is increased requirement is increased when you put on RRT. Similarly, antibiotic dosing, don't underdose. At least give the full dose. So preferably, if you give loading dose, that is better, and your maintenance dose should also be full dose. Okay, because of this concept of augmented renal clearance. So this was a survey done sometime back, taking from 10 to 12 units. So based on RRT and ECMO. So the choice of RRT was 100% wanted to do CRRT or no. So second question was the indications for fluid overload. That time itself, many were keen on doing. For like 40% wanted to do fluid overload as an indication for initiating CRRT, and that is a good thing. Some people even initiated ECMO, CRRT for prevention of fluid overload. That is also another interesting fact. So majority of the units take post-oxygenator, return it pre-pump or post-pump, and some units take it post-pump and return it pre-pump. Okay, we wanted to know how difficult it is to do RRT on ECMO. You can see like the difficulty score of 7 was there. So that means many units had found it little difficult to initiate RRT on ECMO. So this was done 2 years back. So maybe now many units are even more comfortable. So they may be, the difficulty level would have probably come down now. So take home messages, ECMO means remember edema. So that means you'll have to keep RRT in your mind for fluid removal and always calculate fluid overload percentage. Don't wait for AKI to set in. Do early fluid removal by initiating early RRT. CRRT is the best way. Don't do other methods. And we prefer to do inline along with ECMO rather than using a separate ECMO access. ECMO separate access for CRRT. And connections always from the positive to negative side. And don't return anything post-oxygenator. Beware of air bubbles, and preferably CRRT technicians or perfusion is a dedicated person to handle these connections. Thank you. Any questions, anyone? If not, I think we'll just move to the next talk. Could you please explain the prescription part again? How much fluid balance should we target? Okay. So, the prescription part is just like similar to any CRRT. You don't need a separate prescription. I'll just try to show that slide again. Sort of there. Okay. See, CRRT prescription is usually blood flow rate we said. So that is like usually 3 to 5 ml per kg. Suppose this patient was 14 kilos, so we had said 5 ml per kg CRRT blood flow rate of 70 ml. Okay. So your in CRRT you want the effluent dose, clearance dose, no? That is called effluent dose. Usually it is around 30 ml per kg. Okay. So 30 ml per kg for 14 kgs will be 30 into 14 will be 420 ml. Approximately we keep 400 ml for convenience. So in that half will be like 50-50. Like 50% will be for your dialysate fluid, 50% will be for your replacement fluid. So which means 200 ml will be for your dialysate and 200 ml will be for your replacement. Additionally will be fluid removal. Initially there will not be fluid removal at all because the patient may be a little unstable. Once you find the patient is like after 24 hours sort of stabilizing, you can focus on fluid removal. That will be the prescription. Okay. The fluid removal target will depend on the hemodynamics and how much he tolerates fluid removal. It is always a trial and error. Generally, 1 to 2% at least you should aim to remove. 1% meaning, I usually remember it this way. So if you have 14 kg patient, you just add 0 to it. 1% will be 140 ml. Okay. 2% will be 280 ml. So something like that. So you can at least target 1 to 2. If you are able to achieve more than that, that will be well and good. Okay. So that's why you're supposed to measure. Usually the first 2 days, in the first 2 days, your aim should be to avoid fluid balance, avoid positive fluid balance, because of SIRS there'll be some fluid requirement. So if you don't go into positive fluid balance state itself, that'll be a good thing. So next question on the inline filters, does it handle potassium also? No. Inline filter is only for fluid removal. Suppose you want to remove fluid, it will remove. It will not take care of any electrolyte disturbances at all. So it's just fluid removal.
Can we move on to the next?
Yes, ma'am. Thank you, ma'am.
Hey, thanks. Vasant, thank you so much
Thank you, ma'am.
for the excellent batting. And Rajnikant, I hope that delegates have decided CRRT or ECMO, who is going to be Rajni, who is going to be Kamal. Can we see my slides?
Yes, ma'am.
Okay. Yeah. So good evening, everybody. We're going to just discuss about anticoagulation and a little bit of bleeding and choice of transfusions on ECMO. So for those who want to see a machine and haven't seen, this is the pump, this is the oxygenator, this is the heat exchanger, and you can see all this. The dark blood is going from the patient, and the bright blood is what goes back from the oxygenator to the patient. And you can see this was one child carotid internal jugular cannulation for ECMO and transported, and this is how it is. So you can see the blood is, there's so much blood extracorporeal, and it needs anticoagulation. So that is the bane of ECMO. You need anticoagulation, and that too for a prolonged period of time. And it is a very tightrope balance. You want to avoid bleeding in the patient, and you want to avoid at the same time clotting in all this circuit, this contraption. So these are the 4 A's of ECMO: anticoagulation. Along with that are the ACT, APTT, and anti-10A. So let's talk about the ACT. They're very cheap, available, easy. We are all familiar. It's whole blood assay. Whole blood means the platelets are also included in the test. So any platelet disorder will be reflected in your ACT, both qualitative and quantitative. And this is the range we usually target on ECMO. So what are the disadvantages? It gets prolonged with thrombocytopenia, platelet dysfunction, with hypofibrinogenemia, and ECMO, there is a lot of consumption of fibrin. Coagulation factors, all the coagulation factors are consumed in the oxygenator in the circuit. High D dimers common, so you can have can be prolonged. Hemodilution, anemia. So it is, as you can see, it is not a reliable reflector of heparin. So we say you titrate your heparin based on ACT, but you know there can be many other confounding factors which can cause a falsely prolonged ACT on ECMO. And these are the factors that I have listed. So now we'll go through different case scenarios. This was a 2-day neonate VA ECMO for meconium aspiration on very high heparin. Despite the high heparin, the ACT is not, very high. It's not reaching our target range, but APTT is already high. So what can be the cause? So remember, infants and neonates, APTT is generally prolonged because of coagulation factor deficiencies. So the normal levels, blood levels of, your coagulation factors do not reach adult levels only after 4-5 years. And hemodilution also can prolong your APTT, especially when you are starting your ECMO. Heparin resistance, they have low antithrombin levels. So because the antithrombin levels are low, they require much higher heparin for the same effect. So for getting the same ACT, you need much higher heparin on for neonates and infants. So APTT, what are the caveats? So advantages, it's plasma-based, so it's not influenced by your platelets. And this is the range that we target. So it's useful both for heparin as well as your direct thrombin inhibitors like your bivalirudine, etc. But disadvantages, it does not differentiate between heparin, and if you have other coagulation factor deficiencies, if you have liver dysfunction, hemodilution, hypofibrinogenemia, all these can also cause prolongation of your APTT. So falsely low. So you don't have any problem, but your APTT is still low, that could be because of acute phase reactance and risk of bleeding. So what would happen if your APTT is falsely low because you have high acute phase reactance and inflammation? If it's low, then you would increase your heparin, and this can cause bleeding. Now, if it is falsely high, so it is not due to heparin, but it is elevated because of a lupus anticoagulant, especially in adults, factor 12 deficiency. So then if you reduce your heparin, there is risk of clots, because we know lupus anticoagulant, factor 12 deficiency actually cause more thrombosis and clots. But it will reflect on your APTT, and you may wrongly reduce your heparin, thinking that the high APTT is because of the heparin and not because of these factors. So similarly, high fibrinogen will cause falsely low, whereas your factor 12 deficiency and all these, which we normally don't measure. So you can see that APTT is not perfect and can be influenced by other inflammatory factors. So this was a child pneumococcal sepsis. So whatever I'm talking, though I'm saying pediatrics, the same principles apply even for adults. So pneumococcal sepsis, ARDS mods on heparin because of the high, lower heparin because of the high ACT and APTT. But despite, high ACT, APTT and low platelets, you have clots in the circuit. So why do you think, why is this happening? Remember, I told you ACT is also influenced by your platelets. You have such a sick patient with MODS. I'm sure there's coagulation disorders. So that can be reflected in your APTT and not your heparin. So you can have a DIC picture where you can still clot in the circuit and bleed in the patient. So what is this anti-10A? Anti-10A, we know heparin, both low molecular weight and unfractionated, has to bind to antithrombin to inhibit the free thrombin, and that will inhibit your 10A. So this is what we measured your anti-10A. So remember, in infants, this antithrombin, sepsis also, your antithrombin levels are very low. So that means even though you're giving good heparin, your anti-10A may be falsely low and you'll need much higher. You'll have to replenish antithrombin. Also remember, if there are clots in the circuit, heparin does not, it only inhibits the free thing. Any clots that are formed is not going to dissolve. Whereas bivalirudine, that is the direct thrombin inhibitor, can also both free clot and fibrin clot also, it does have effect. So anti-10A, the advantages, it is the gold standard. Now, we at Apollo have it and a few other hospitals, but not all hospitals have anti-10A. But it has a good association with heparin dose because it is not influenced by your platelets, fibrinogen, your coagulation factor deficiencies, etc. It's not influenced. The only thing it is influenced is heparin and antithrombin. Target range is 0.3 to 0.7. And if you know there is a prothrombotic state, lupus anticoagulant, whatever, then you would target a high fibrinogen, you would target a much higher range of anti-10A. Disadvantages, it's falsely low, it's chromogenic. So colors, your bilirubin, hemolysis, hemoglobinuria, etc., can cause falsely low anti-10A, right? And hemolysis can occur on ECMO. It is not useful for direct thrombin. So if you're using bivalirudine, agrobetan, it is not going to be useful. You need your APTT. Now, I told you low anti-10A levels means either there is a loss. Now, Dr. Vasant mentioned that heparin can be lost by diuretics. Heparin can be lost by CRRT. So then you'll have your low anti-10A levels and you have to give a little more heparin. Or it can be due to low antithrombin levels, which because of sepsis, or you've used a lot of heparin, which has consumed your antithrombin, or infants and neonates where, they have low antithrombin levels. And it's expensive, not easily available. So this is another scenario. This was a patient with, VA ECMO for myocarditis. Urine was turning, a little darkish. You can see the dark urine there, hemoglobinuria, and there were some clots in the pump. We were giving good heparin. The ACTs were good range. APTT was fine. Platelets were not too low, but the anti-10A was low. Can you tell me why? Can you all tell me why? So I said it's a chromogenic assay. So hemolysis, and in children, the small caliber cannulas and all cause more shear stress. Hemolysis occurs also when you have a lot of connections. If you put your CRRT in the thing, we see our carboxyhemoglobin going up, which is the reflection of hemolysis. And oxygenator clots can also cause DIC with bleed. So your anti-10A can be falsely low if you have hemolysis. But it is the gold standard, and all these studies say that it's not just good, but it is great. And though the test is expensive, you actually save on blood products because you know you are correctly. You don't change your oxygenator. The oxygenator doesn't clot. It's a lot more. This is the systematic review. So anti-10A based coagulation has fewer bleeding events and no thrombosis in the circuits. So it is actually you're targeting because it's only influenced by your heparin and antithrombin, and it will prevent clotting in the circuit. But now, what is is there any concordance between APTT and anti-10A? So I told you, if you have high APTT and a low anti-10A, high APTT, so coagulopathy, it's not only heparin that's influencing the APTT. Coagulopathy can affect your APTT. If you have low anti-10A, it's because of hemolysis, hyperbiliary, hyperlipidemia. Now you have high anti-10A but a low APTT because of acute phase reactants, which can falsely lower your APTT. So the concordance is somewhere around here. In the extremes, when these factors play a role, could everybody silence, please? Thank you. Then it may not really correlate if you have this extremes. So this is your ELSO 2022 guidelines, which actually say you still have to do your APTT and anti-10A to ensure that the patient doesn't have any bleeding, right? So if both are low, you increase the heparin. If APTT is normal, but your anti-10A is low, you still increase heparin because you don't want the patient to clot in the circuit. If both are high, then you may consider FFP just so that your APTT is not too high, okay? And if there is, if your APTT is low and anti-10A is normal, hypercoagulable state because of high fibrinogen. So this is exactly what I told. Remember, anti-10A can be low, falsely low because of hemolysis, hyperbilirubinemia, because of heparin and antithrombin. These are the only 4 things that can influence your anti-10A. Heparin, antithrombin, hemolysis, hyperbilirubinemia. And things that influence your APTT are your coagulation factors, fibrinogen, factor 12. So the pluses and minuses of the test: ACT, point of care, inexpensive, but is not a reliable reflection of heparin alone, and it can be falsely prolonged in other states. APTT, accepted, but inexpensive point of care, but it can also be falsely prolonged by coagulation factor and hypofibrinogenemia and acute phase reactants, which can actually falsely lower it. Anti-10A, good measure of heparin, those more expensive and can low in the presence of any colors, hemolysis, hyperbilirubinemia. TEG. Now, these are the viscoelastic test. These are very good when the patient is bleeding because it tells you the clot formation strength. We are not going into detail, but this is excellent if you have it available for bleeding patients. Now, this was a patient ARDS, VB ECMO. You can see your ACTs are high. APTT is also high normal. Anti-10A is low, platelets low, the fibrinogen is low. Now, if we do only APTT-based test for ECMO, the assumption would be excessive heparinization and heparin infusion would be withheld, but the risk of clot would still be there because your anti-10A levels are low. So the patient, you are preventing bleeding in the patient, but you could still clot in the circuit if you stop a heparin. If you do only anti-10A in such a scenario and not your APTT, then you would be unaware because anti-10A is low, you would go up on your heparin, and you would be blissfully unaware that the patient is at high risk of bleeding because your APTT is high. Because of different factors, the patient has got sepsis and has every reason to have low fibrinogen, high APTT because of your coagulation disorders, hyperfibrinogenemia, etc. So on ECMO patients, if we have the luxury, it's good to do platelets, ACT, APTT, and anti-10A. ACTs in the initial few days, and after that, APTT and anti-10A are quite reliable. Now, this was a patient, staph sepsis, toxic shock, VA ECMO, MODS on CRRT. So CRRT, now look at these. APTT is low, your fibrinogen is high. So I did tell you that high fibrinogen can cause falsely low APTT, even if you're giving good heparin. Now, low platelets can influence your ACTs. They can cause prolongation in your ACT. But we're giving very high heparin, 40 units per kilo per hour, normally for adults and older children, it's 20 unit, 20 to 25. Newborns, maybe 30. But why is this so high? And still your anti-10A is low. So what did Dr. Vasant say? If you're on CRRT or you're on diuresis, this heparin could be lost in the circuit. That number one. Number two, if you have low antithrombin levels in a septic patient, your anti-10A can be low because heparin needs to bind to antithrombin to reduce to have effect, anti-clotting effect. So this is called heparin resistance when you're requiring very high heparin, but you are having low ACTs, low anti-10A, despite escalating doses. And what are the causes of heparin resistance? One is antithrombin deficiency, infants, sepsis, DIC, liver disease, etc. Or prolonged use of heparin. Heparin clearance, diuretics, RRT. Elevated acute phase reactants. Remember, there are many acute phase reactants, proteins that compete with antithrombin. So especially in the acute inflammatory phase. So, and also heparin binds to heparin binding protein. So whenever you give platelets or plasma, you'll actually see your ACTs may not go up. Some centers routinely, when there is high risk of clotting, they go up on the heparin infusion just before giving their platelet transfusion because the heparin binds to heparin binding proteins. So, and the platelet 4, etc., which are present in these blood products. So what do you do for heparin resistance? If your ACT or APTTs are not increasing with increasing doses of heparin, then you just give higher dose of heparin. You supplement antithrombin. Now, we don't have the luxury of having antithrombin concentrates which are present in the West. So we give fresh frozen plasma, which is the poor man's antithrombin. And so this fresh frozen plasma is not for bleeding. It is actually to replenish antithrombin levels so that you don't have clotting in the circuit, and heparin can bind well to antithrombin to prevent clot. Or switch to an alternate anticoagulant like bivalirudin if too many clots are being formed. Now, this is heparin-induced thrombocytopenia. So heparin is very easy, it's cheap, but it does have its problems. So you have two types of heparin-induced thrombocytopenia. One, you'll have a transient platelet drop, which doesn't cause any problems in the initial days, which is not immune-mediated. Whereas this, after a few 10 days of use of heparin or so, you can have this immune-mediated drop in platelets. And this is the 4T score. So this is clinical. We had a patient with this erythematous rash. And if you look at this, the 2 points for this proven thrombosis, skin necrosis. So you can have some erythematous skin. And there was no abscess. We did an ultrasound. There was no abscess. And the oxygenator kept clotting. I mean, the circuit kept clotting. We had to change the oxygenator every 24 hours. So we changed so we knew this was a patient with HIT. Because the 4T score was strongly positive, also developed mesenteric ischemia. We changed the oxygenator circuit, and finally we switched from heparin to bivalirudin. So bivalirudin, now more and more centers, ECMO centers are switching over upfront. They're not even trying heparin, they are going over to bivalirudin-based anticoagulation. And this is a systematic review, even in pediatrics, lower bleeding, transfusion requirements were less thrombosis, and it is safe. So you just need an APTT, and remember, it dissolves already formed clots as well. So it's a cost-effective alternate. Because though the bivalirudin is expensive, the number of tests, you don't need to do ACTs, you just have to do once or twice a day APTT. So the number of tests you save in the test. So remember, where does heparin and low molecular weight heparin act? In this factor 10A, which inhibits your thrombin, whereas direct thrombin inhibitors directly inhibit the thrombin to dissolve your fibrin. Okay, so this is the difference. These are indirect thrombin inhibitors. Bivalirudin is direct thrombin inhibitor, and you need antithrombin for heparin effect, whereas bivalirudin, you don't need any other cofactor. It does not cause HIT. Bivalirudin does not cause HIT, and it also dissolved formed clot. Okay. So this is from PCCM. This was in a survey, and which actually in 2021, and which showed that 51% replace antithrombin. We use FFP. What has changed? Small number of centers have moved to bivalirudin, and this is in 2021. So I'm sure by 2024, more centers are using upfront bivalirudin, and shift from predominant use of ACT to near universal utilization of anti-10A. So 90% are using only anti-10A. And you can see this 86% are using anti-10A plus ACT, 43% anti-10A plus ACT per APT. So most of the centers, in fact, all are using anti-10A. So anti-10A is factoring in all, right? So this was a patient with cannula side day 3 nasal bleed. You can see the bleed here. The ACTs were fine, APTT was fine, platelets were okay. So what is the cause of the bleed here? Can anybody tell? So you have all got normal numbers, but the patient is still bleeding. So this is very, very important, which occurs in ECMO. It's a unique problem, and that can cause bleeding, acquired von Willebrand deficiency because of shear reduction and shear stress. There is cleavage of your ADAM13 of your high molecular weight von Willebrand factor. And remember, all your tests can be normal and patient can still bleed. So there is consumption of coagulation factors. And what are the coagulation factors that are consumed? Factor 13 deficiency occurs on ECMO. Von Willebrand deficiency occurs, and you should consider in bleeding patients with normal APTT, fibrinogen, and platelet counts. How do you treat it? Desmopressin, von Willebrand factor concentrate, we do not have. So cryoprecipitate you can give. Tranexamic acid, you can put local. So if they're bleeding pulmonary, you can nebulize the tranexamic acid. So this patient had a brain bleed. You have listened to the talks yesterday. Can somebody tell me this was a patient, 4-year ECMO, adenovirus ARDS, all the factors were normal at initiation, platelets. 24 hours later, he's hypertensive, pupils unequal, and this is the CT. Can anybody tell me why this patient bled in the brain? So look at this. This is the PCO2. The PCO2 at initiation was 116. Now, if the PCO2 was dropped the minute you initiated ECMO and you are already anticoagulating the patient is hypertensive soon after initiating ECMO, there is high risk of bleed. So beware, kids have higher risk of brain bleed. Mind the rapid drop in CO2 and the rise in blood pressure in kids. You need to have your SNP ready when you are putting cannulating patients on VV ECMO, because from hypotension, RV dysfunction, and it will switch over from hypo to hypertension when there is no acidosis, when you correct your PCO2 very rapidly. Remember, CO2 is very diffusible and that normalizes very, very fast on ECMO. So first 3 hours, don't drop your PCO2 more than 25. And in pediatric patients, the delta CO2 in the first 24 hours should not decrease by more than 30% because higher risk of neurological complications. Now, viscoelastic test, TEG, ROTEM, ClotPro, etc., they're very useful in bleeding patients. But they're expensive. They cannot detect von Willebrand deficiency. You can still have a bleeding patient with the TEG normal, so do suspect von Willebrand deficiency. Now, this was another, these are patients who have, this was a 4-year child, x-rays of patients with some pneumonia, ICD placed, and you can see from pneumothorax, we've actually converted into a hemothorax. So procedures on ECMO, be it children or adult, please think twice whether it really warrants. So this pleural hematoma had to be warranted VATS and exploration on ECMO. So that actually caused more problems than the early. So only insert in, do procedures if it is going to make a difference. Otherwise, don't put rectal tubes, don't insert ICD unless there's a tension pneumothorax. Now, another scenario, 2-year child, influenza pneumonia, ARDS, gross melena, then heparin was stopped, blood products, again, heparin restarted. These are all real scenarios that I'm sharing. Episodes of melena, heparin stopped on and off. Then there was hematuria. So, there were periods when the heparin was stopped or, ran very low till decannulation, continued ECMO without heparin. So what I'm trying to, the message that I'm sharing is heparin-free ECMO can be done in patients who have high risk of bleeding or who are bleeding. You don't have to withhold ECMO or stop ECMO. Just target lower ACT and APT targets because of bleeding, run very low heparin or and increase their pump flows. So this is in 2023, anticoagulation-free pediatric ECMO, and even for 135 hours, heparin-free ECMO was deployed. So how do these tests help at bedside? Anti-10A ACT. They help preventing clotting. APTT platelets tech will help prevent bleeding on the patients, and together they make sense. You cannot look at one in isolation. So just a little bit about patients bleeding on ECMO. So where do they bleed? Major ECMO cannulae site, hemothorax, pericardium, ENT bleeds. So your nose, ET bleeds, lines, surgical wound site, GI bleeding, hematuria, hemoptysis. So these are the usual sites. And the reason why they have this problem is because of this negative. So Vasant told you that pre-pump pressures are all negative. Post-pump pressures are all positive. So imagine your blood is sucked, RBCs, fibrin, platelets, everything, and then it goes around the pump and rotates from negative pressure to positive. There's a lot of shear stress, von Willebrand deficiency, platelets are consumed, platelets are destroyed. It's called thrombocytolysis. Coagulation factors are, consumed. Fibrinogen is also consumed, and therefore there is enough reason for ECMO-induced coagulopathy, also because of the SIRS inflammation, right? And this, von Willebrand. So you need your Bernard Solier, all your GP endothelial cells. So there is no proper endothelium when you have the blood running in the ECMO circuit. And that is the reason why. Plus, it's not a pulsatile flow, it's continuous flow. So there's more risk of, it's a double hit on ECMO because of all these problems. So blood components on ECMO. There are multiple studies which have showed that every transfusion can cause problems. Even 10 ml per kilo was associated with a 9% increase in odds of mortality on ECMO. Mortality was higher in those who received large RBCs. 10 ml per kilo of platelets associated with mortality. RBC transfusion and platelets increased hospital mortality. Why? Because of complications of transfusion. It causes TACO, TRALI. So you already have put on ECMO for bad lungs, and if you keep giving platelets, there's high risk of TRALI. Immune modulatory, it causes immune suppression. Blood products do cause immune suppression. They cause sensitization, and then after that you have antibodies to platelets, and your platelets will not rise. Infections, especially with platelets, because platelets are not stored, and therefore they cause more infections and sepsis. Plus storage lesions. They cause, membrane stiffness, decrease deformability, your 2,3 DPG is reduced. So it's not necessary that giving blood products is going to make a lot of difference. And so now ECMO transfusion goals have changed. For hemoglobin, it's 7 to 9. Yesterday, Shubhadeep actually mentioned, consider 9 only for patients with cyanotic heart disease or, very hypoxemic with end organ dysfunction. Otherwise, 7 to 9 is good enough. That is, these are the new guidelines by the ELSO. So Oxygen Balancing Act, just targeting hemoglobin number, does delivery equate to consumption? Now, will you be causing more hemolysis by giving more RBC transfusion? So one size does not fit all. If your hemoglobin saturations, if you're lactate, if you don't have hypoperfusion, you don't chase the saturation number. Don't chase the hemoglobin. So use 9 grams hemoglobin if the sats are very low, and 7 to 8 even if your sats are sitting around 88 to 92. So there is insufficient evidence to recommend a specific RBC, but don't chase numbers if the patient is otherwise looking fine, except when you're maybe weaning the patient. Platelet transfusions, better to give single donor because the increment is higher and it's only from one donor. So antibodies are also less rather than giving multiple random donor platelets with lesser increment, more alloimmunization. FFP, so all the guidelines, Canadian, US, say, this is the ELSO guidelines, target INR 1.5 in bleeding and less than 3 in non-bleeding. So don't unnecessarily give FFP unless you want to replenish antithrombin. And this is the rise of your fibrinogen if you give 10 ml per kilo. Cryoprecipitate, in non-bleeding, more than 100. And if it is bleeding, you will want a higher range of fibrinogen, so 150. Remember, cryo, what does it contain? It contains your von Willebrand factor and factor 13, factor 8. Whereas your FFP has lower concentration of your, fibrinogen. So if you want to correct fibrinogen, just give cryoprecipitate, whereas FFP has all the other coagulation factors. Viscoelastic test, these are different shapes. When you feed it to this machine, TEG or Rotem, you will get these different shapes, and it will tell you whether you have to give platelets, whether you have to give coagulation factors, whether you need to give tranexamic acid or your cryoprecipitate. So it's very precise, specific blood product useful for bleeding patients. Now, they can bleed systemically or locally. So you can reduce or stop anticoagulation, I mentioned, increase the ECMO flow so that the circuit doesn't clot. local hemostasis in the wounds cannulae. If there's GI, you can give octreotide. Remember, factor 13 deficiency has normal APTT, transfuse platelets. Above 50,000 is fine unless you're doing a procedure. Sometimes if the patient is very stable, even we are okay with 40,000. So hyperfibrinolysis, tranexamic acid can be given applied locally, nebulized, and acquired von Willebrand. Now, I said increase the pump speed when you reduce anticoagulation, but if you increase the pump speed, there is more shear stress. So you can actually be worsening your von Willebrand deficiency. So be mindful of that. Don't increase your pump speed for too long because it's causing more shear stress and more destruction of platelets as well. So less is more, many factors influence tests. Anti-10A is more specific and a gold standard. And you have to closely monitor and for all and have sensible interpretation of all your tests to prevent bleeds in the patient and clotting in the circuit. Stop, think before transfusing blood products. Thank you. Any questions? I see no questions.
Thank you, ma'am. It was a nice talk. Just I wanted to tell one more comment on this bleeding issue. How can we prevent it? So practically, before putting on ECMO, we need to keep your NG in place, Foley's in place, two or three good cannulas in place, and put an arterial line. So don't put any peripheral radial arterial line or so big because it is of low caliber and it may get kinked and it may get it might work in next 4-5 days. So always insert a well secured femoral arterial line so that it will last for a long time. So these things, and never put any enemas for constipation. So these are simple things that we need to look into before when the patient is in ECMO. And again, we can run without heparin for a good number of days. Currently, we have one adult RTA with frontal contusion, EDH, ARDS. And for last 4 days, we are running without heparin. Luckily, we didn't have any clots or so. Oxygenation is good. Post-oxygen saturations are around more than 450 or so. And the pressure drop is also between 15 and 20 millimeter mercury for last 3-4 days. Anyway, now it is 7 day of trauma. I had discussed with Dr. Amisha as well regarding the same. How long can we go without heparin? So nowadays these circuits are well designed. So this might be a problem for adult population at least because the flows are very high. The Heathen flows are 3.5 4 liters of flow we are giving. So, but pediatrics may not be practically possible. Sometimes we may end up in problems because our flow rates are, especially if neonates or infants, flows are very less. So, as per which was tried, the lower the flow chances of clotting are high. So, this is one of the other things that we need to look into.
If there are no further questions, we can move on to the next. Dr. Shiv is here.
Hi.
Hello, hi Shiv. So it's pleasure. Shiv, you can start sharing. Pleasure to invite Dr. Shivakumar. He was my colleague at Apollo and then moved over to Bangalore, where he heads the pediatric ICU and the ECMO program at Manipal Hospital. So he will be taking you through monitoring on ECMO. Over to you, Shiv.
Thank you, Chief. Are my slides seen?
Yes. But you have to make it full screen. Yeah. Perfect.
Audible?
Yes.
Okay, thank you. Okay, so have we done initiation, Chief, or I'll skip this?
You can just cover it briefly. What is going to come in initiation?
Okay, I'll just try and speed this up.
Yeah.
Okay, so initiation on ECMO, I think once everything is set in place,
This is
few
good.
things.
This is good. This is good checklist. Yeah.
Okay. Yeah. So it's important to have to make sure that the cannulas are well secured and functional. All connectors and stopcocks in the circuits are well secured and in proper directions with no risk of air embolism or blood leakage. The pressure monitoring and flow sensors need to be checked. Make a note of the patient vitals before you start. Make sure you have a crash cart available, because once you initiate ECMO, you expect that there could be a lot of fluctuation, especially in the hemodynamics. Make sure your vasoactive medications and fluid boluses are available readily. Sometimes it's even connected. Most of the times we have vasoactive medications going, but you might have to increase the dosage of the vasoactive medications just prior to initiating the ECMO. Emergency medications must be loaded in syringes and available, and everybody should know in a crash kind of situation what dose has to be given. And of course, bolus heparin, which is usually a call from the surgeons, whenever, usually when they do the Seldinger technique, when the guide wire is in, usually they ask for heparin to be given. So that's when the bolus heparin is given. Make sure all these are done before we go on to initiation. So we look at the following 4 categories, sections of initiation. When it comes to blood flow initiation, we make sure the venous end of the circuit is connected to the drainage cannula in the patient. The arterial end of the circuit is, connected to the return cannula of the patient. We usually unclap the venous cannula first and start centrifugal pump. Generally get it to a rotation of about 1000 RPMs, and then unclamp the arterial side of the pump. Slowly, RPM is increased, and blood flow is slowly increased gradually. And at the end, what we want is acceptable flow. By acceptable flow, what I mean is whatever gives you the best perfusion parameters in the form of mean arterial pressures and clearance of lactate, good urine output and venous saturations. Now, extracorporeal gas exchange parameters. When we talk about initiation, we're talking about the following things. We start with 100% FiO2. Sweep gas flow to blood flow ratio usually is about 0.5:1. And we aim to lower PCO2 gradually. I think the previous 2 speakers have already mentioned the importance of it. And titrate the sweep flow to the blood flow. And we also have to check for the color change in the drainage and return cannulas. So you'll see that the return cannula is dark colored, and the drainage cannula is dark in color, and the blood in the return cannula becomes very bright. That difference in color tells you that the oxygenator has started working. And also we need to make a note about what the pre-pump, the post-pump, the pre-oxygenator pressures are, because that is your baseline now on which you'll work for the further monitoring of these pressures. And of course, note the RPM. At that RPM, how much is the blood flow you are getting. We also set alarm limits and temperature of the circuit. The next thing is to make sure that the patient, hemodynamics stabilize and the patient ventilator settings are done. Usually we go to rest settings. I think yesterday you had a talk on, what is how do you do ventilator management in VV ECMO? And then we titrate the sweep gas based on the blood gases. We also monitor for adequacy of perfusion, looking at the mean arterial pressures. And also, if required, initiation of vasoactive medications and titration. Generally in VV ECMO, if there's no major hemodynamic issues, we tend to kind of come off the vasoactive medication. The same thing happens with VA ECMO also once we go on full flows. Anticoagulation, of course, we start monitoring ACTs, and initial ACTs are expected to be high because the heparin bolus is given. So we repeat ACTs every 30 minutes, make sure the ACT drops less than 200, and then initiate heparin as a slow infusion at around 8 to 10 units per kg per hour, and then titrate to our endpoints of ACT to begin with. And then, of course, whatever discussion we've had about anticoagulation needs to be followed. So common issues that can happen during initiation, at the immediate part of initiation, is there can be significant hemodynamic challenges in terms of sudden bradycardia and hypotension. Generally think of hypovolemia, severe acidosis, or electrolyte abnormalities. So a fluid challenge, is usually the response. And of course, increasing the dosage of vasoactive medications, ensuring that the acidosis is corrected. And if there's any obvious electrolyte disturbance, that needs to be addressed immediately. Hypertension is another challenge that can come up, especially with, VV ECMOs, because we are concerned about causing bleeding complications because they're already on high dose heparin. So that needs to be tackled with immediate effect and effectively. And flow issues can happen. It can be because of the mechanical problems like cannula size or position, or bleeding complications like tamponade, or there could be air leaks like pneumothorax, which can cause problems with flows. or otherwise think of capillary leak or hypovolemia itself. Then poor oxygen saturations, arterial, that is another problem which can happen. You'll have to see if you have got adequate flows going. Generally, oxygenator failure does not happen so early during initiation, but sometimes your oxygenator, if it is small for the particular size of the patient, for some reason, that is something which you have to look at. But usually it is related to poor flows or improper connection of oxygen, or recirculation that can happen. Those are causing the acute oxygenation problems. The other thing could be increased demands. The patient is not adequately sedated, or the patient is septic. So the native flow itself is, causing dilution of the oxygenated blood. So these things which we'll have to address with respect to oxygen saturation. Now, arterial pulsations, usually there is, especially with VA ECMO, you'll see that there is damping of the arterial trace. With VV, because it is the cardiac functions are separate, usually we don't see those problems, but we need to kind of optimize the mean arterial pressures. And of course, circuit color, we already discussed about it. Coming to monitoring, I think it's very important to monitor these patients closely, because complications on ECMO is not an exception but a rule. So we need to keep that in mind. And usual programs, they run so well that usually nothing happens most of the time, but when things go wrong, they go really bad. So monitoring is very, very important, and because prevention is the paramount rule. Because when complications happen, it is very difficult to tackle them, very quickly and address them at best. So why it is so important? Because in the early phases, the patient is so sick, they've got an ECMO and they're completely dependent on this technology. So you don't want anything to go wrong, especially clotting of oxygenator or circuit, blockage of cannula, air embolism, accidental decannulation. These can be catastrophic, especially in a patient who's completely dependent on ECMO. At the same time, we need to ensure that the safety of the patient. At the same time, we'll have to balance the safety of the circuit as well, and monitor the efficacy of therapies. For all these reasons, monitoring is very, very important. When we monitor a patient on ECMO, we're looking at two circulations. One is the native circulation of the patient itself. The second is the circulation that is happening through the ECMO circuit. Okay, so native circulation, we look at the patient vitals and perfusion parameters. And in order to maintain the native and the ECMO circuit, we do something called lab monitoring, which we'll come to. So think about what all can go wrong and what can be done to prevent these complications, how to identify them early and how to address them. So that is, if you can think of these things in a patient, then you'll know what exactly to monitor. So I'm going from head to toe, just not that it has to be in the same order of monitoring, but just to make sure that we don't miss out on anything. So from the head point of view, what can go wrong is they can have bleeds, they can have infarcts, they can be cerebral edema, there could be embolism, there could be seizures. All these things can happen in a patient when they're on ECMO. So how do we monitor them clinically? It's looking at the consciousness, the pupillary sizes and reaction, limb movements, reflexes. But these are challenges because most of these patients, especially pediatric patients, we tend to sedate them deeply because we're worried about, cannulas and endotracheal tube and so many other things that, that is running on in these patients. We don't want anything to go wrong. But it's also important to monitor their neurology. So every day we have to make sure that we give them sedation holidays. If you are using continuous infusions of paralytics, make sure we give a break. And just for a brief period of time, we examine these patients and, just make sure there's no focality to examination, the consciousness is okay, and the limb movements are okay. Technology is another thing, and very useful. Bedside technology is the one which comes to help in these situations because it's not easy to move these patients to neuroimaging, like doing a CT or MRI very often. Those are done in really extreme situations when we are seriously considering something major, catastrophe has happened in the head. But otherwise, most of the time, the monitoring happens clinically and also by bedside technology. It could be optic nerve sheet diameter, transcranial Doppler, whichever is the expertise that you have in your unit. Bedside EEG monitoring, all these things can be utilized to monitor these patients neurologically. Let's come to lungs. What can go wrong? There could be hypoxia, despite being on ECMO. There could be hypercapnia. Lungs could get into trouble with pulmonary bleed because you're on anticoagulation, and there could be necrotizing pneumonia itself, which causes bleed. Pulmonary edema is one of the complications that can come up with VA ECMO, especially with a stunned myocardium. There could be mucus plugging and non-aeration of lungs, and that might be the reason why your lungs are not, improving. Prolonged intubation needing tracheostomy, development of effusions, air leaks, all these things can happen with respect to the lungs. So monitoring of the lungs, usually we go into rest ventilator settings. By rest ventilator settings, it varies with units. I think yesterday you already had a discussion, so I'll not go deep into that. Monitoring lung compliance is very, very important. How do you monitor that? Generally, we tend to put them on pressure control ventilation, and we'll see that as the lung compliance is getting better, the generated tidal volume improves for the same amount of delta P. The other way to look at the lung is to look at aeration on the chest X-ray, the requirement of the sweep gas, the requirement of the oxygen on the ECMO. All that kind of gives us an idea about how the lungs are behaving. At the same time, end-tidal CO2 monitoring. What happens is when you begin ECMO on a bad lung situation, especially VV ECMO, you see that the end-tidal CO2 monitoring is not, coming up. The numbers are very low because the amount of air that is going into the lungs and coming out of the lungs itself is low. As aeration improves, this EtCO2 kind of tracing becomes better and better, and the numbers start coming up. So that is another indication that the lungs are improving. Spontaneous breathing on ECMO is something that is desirable, but then in the early phases, because of so many other things happening simultaneously, we tend to keep them adequately sedated and paralyzed, especially pediatric patients. But bigger adults, adolescents, who are spontaneously breathing and not having excess work-up breathing, that's very important, because then you're talking about increasing oxygen consumption and also increasing transpulmonary pressures that can actually, affect the recovery of your lungs. So if they're comfortably breathing spontaneously without having any significant cough and other things, we could permit that. That may help the lungs to recover. Oxygen saturations need to be monitored. Remember, it is different for VA and VV ECMO. In VV ECMO, we expect the saturations to be lower. What is desirable is about 90%, but we do accept lower saturations as long as the end organ oxygenation parameters are okay. By that I mean you're looking at lactates, we're looking at how the child's hemodynamics are and all those things. Sometimes we have accepted saturations up to 70% also because of the challenges with the severity of the lung disease along with sepsis. In VA ECMO, we usually see that the saturations are good in terms of numbers, like any other patient. And here we have to keep in mind that the saturation probe has to be on the right hand. I'll come to why that has to be on the right hand later. Of course, in terms of technology, we look at chest X-ray, not only look for air leaks, presence of effusion, or how the lungs are aerating, but also important to look at the cannula positions. So cannula positions, although they are sutured and secured well, it can migrate, especially in small children, because and I've seen that happen with respect to neck cannulations, because the neck length itself is less. The cannulas are also very small, and they tend to be the length of cannula within the neck is also very small, so it can easily migrate, and it can be catastrophic if it comes off. So chest X-ray, we have to look at the cannula positions also. Ultrasound chest is very, very useful, and bedside ultrasound has become the fifth vital sign now. I don't think any of us are using stethoscopes nowadays to look for effusions and other things. And of course, blood gas to look at PCO2, PaO2, lactate clearance. Central venous saturations are extremely useful, especially in VA ECMO, which gives us an idea about adequacy of perfusion and cardiac output. And in VV, it gives us an idea about recirculation and other things. Now, CT chest and all is done, in extreme situations. If you're having challenges with, lung recovery, or if you are thinking of any other complication in the, chest that cannot be detected by chest X-ray or ultrasound, then only we go for CT chest. Have you had a discussion about this North-South syndrome? Okay. When I mentioned in the previous slide about having saturation monitoring on the right hand, the reason for that is this, This is a problem that can come up with VA ECMOs, especially when you have, femoral and jugular cannulation, and especially when the heart starts recovering and in the presence of bad lungs. So what happens is that whenever the blood flows through the lungs, if the lungs are not adequately oxygenating blood, this deoxygenated blood can come to the left heart and then gets ejected out through the aorta. And this ejection of the left heart has to compete with the ECMO flow. And if your ECMO flow is low, because you're wanting good ejection to happen, in those situations, this deoxygenated blood can go and supply the brain and the right hand. So the way to pick it up is by looking at the saturations on the right hand. Otherwise, we might miss out on monitoring and understanding this concept, and we might end up having a child with a bad brain. And, the other important circulation that this supplies is the coronary circulation. So your heart will also suffer because of the deoxygenated blood. So this is called North-South syndrome. Now, in terms of cardiac monitoring, all these things can happen. There can be hypotension because of low cardiac output state. There could be hypertension, arrhythmias, especially with the sick myocardium. If you have cannulated a patient for myocarditis, there could be pericardial effusion, more common with central cannulations. And there's something called stunned myocardium, where your heart stops ejecting once we go on adequate flows, especially on a VA ECMO. So clinically, we monitor the heart rate, the rhythm, make sure the rhythm is corrected. Common things that we need to address is acidosis, electrolyte disturbances, ensure there's no hypoglycemia and other things. And then, we also monitor the pulse volume, peripheral temperature, and, arterial blood pressure monitoring. Extremely important to have arterial blood pressure monitoring in these patients. Now, the reason for that is, NIB monitoring is not reliable. At the same time, you will see that when you're on VV ECMO, you have pulsatile arterial trace because your heart is functioning independently. But when you are on VA ECMO, there is damping of this arterial trace, and you really cannot go by the systolic and diastolic numbers. You'll have to go by the mean arterial pressures. And the desirable map, it's this only arbitrary that we look at numbers, but what we want is acceptable flow. When I talk about acceptable flow, we're looking at how the tissue oxygenation is happening, which is indirectly expressed by the blood gas in terms of lactate and clearance of acidosis. And in VA ECMO, venous saturations, anything above 65 to 70 gives us a good idea that there is adequate cardiac output happening. Urine output is another monitoring parameter for adequacy of cardiac output, especially when there is no pre-existing AKI. So venous saturations are usually monitored, at this point here, if all of you can see, it is in the drainage cannula before the centrifugal pump is connected. That's where the venous saturation monitoring is happening. And that can happen even as a continuous monitoring. There's technology available which will reflect venous saturations on your monitor itself continuously. And like I said, in adequacy of, it helps us understand the adequacy of cardiac output in VA ECMO. Normally, the range is anywhere between 70% and above is acceptable venous saturation. If you have low venous saturation, think of, tissue hypoperfusion, low cardiac output state. So we may have to increase the ECMO flow, make sure the hemoglobin is okay, there's adequate oxygen, and look at possibility of sepsis and address that adequately. High venous saturations in VV ECMO tells us that there is significant recirculation happening. So we'll have to check for catheter position. You may have to reposition the catheter. You may have to alter the flows to make sure that the recirculation doesn't happen. It could be because of diminished extraction by the tissues itself, especially with respect to severe tissue injury. And generally, it may indicate improvement also, and we may have to consider weaning if everything else is okay. Now, addressing low venous saturations, if our venous saturations are low, look at the reducing oxygen demands by making sure you're adequately sedating these patients, paralyzing if required. Make sure there are no ongoing subtle seizures or non-convulsive seizures. There's no hyperthermia, so we may have to cool these patients to maintain normothermia, and then optimize oxygen delivery by giving adequate oxygen and hemoglobin content that will improve your oxygen content of the blood and ensuring good cardiac output, which on VA ECMO is to do with ECMO flow. End-tidal CO2 monitoring, I've already mentioned. So it tells us about two things. One is from the patient point of view, it is telling about native lung function, how the aeration is and gas exchange is happening. And second, it also tells us about the adequacy of pulmonary blood flow. Now, these two things can be easily judged by looking at the end-tidal CO2 monitoring. And of course, from the ECMO circuit point of view, we have to titrate sweep gas. So we need to understand how much sweep gas to give, whether to increase, whether to decrease, whether to maintain same. So that then, you can monitor with end-tidal CO2, provided you have a good correlation with your arterial blood gas and end-tidal CO2 monitoring. And it is extremely useful when we wean patients from, either VA or VV ECMO, because it gives an idea about how the lungs are tolerating the process of weaning. So about sweep gas flow rate, it should be set in relation with the blood flow. Usually the ratio of gas flow to blood flow is about 0.5:1 and can go maximum up to 1.5:1. Anything higher than that, you are creating a situation where you can have air embolism. Now, hypocapnia, if there is hypocapnia, we may have to decrease the sweep gas flow. If there is hypercapnia, we have to increase the sweep gas flow to maintain normocapnia. Vascular assessment is very, very important, because these are all, especially in kids, because their vessels are small. We have put large cannulas into these vessels, which are required to, give adequate flows. So compromise of vascular circulation is not uncommon. So they need to be monitored on a daily basis to make sure that there is good peripheral pulse, peripheries are warm, the color is okay. And if there is any concern about the early signs are, feet becoming cold and pulses not being adequate, at that time itself, we may have to take measures to make sure that it doesn't go to extreme situations like this. And the best way to monitor is, of course, clinical, like I said, Doppler, handheld Doppler, or even, ultrasound Doppler flows we can do. And if required, we may have to do CT angio to understand what is happening in this process. GI monitoring, we look at feed tolerance, whether there's any GI bleed through the nasogastric tube or stools, mesenteric ischemia, gut ischemia, gastric ulcers and bleeding. All these things can happen because, you're having a combination of a stressful situation and also significant anticoagulation, which is a deadly combination, and you have a perfect setting for, bleeding complications. And monitor the urine output for hematuria or hemoglobinuria for that matter. The technology that we can use is ultrasound abdomen. Lab investigations in the form of liver function test, renal function test have to be periodically monitored. So a lot of investigations that, goes on, and what we need to understand is we'll have to plan it as required for the patient. Of course, the frequency of these investigations are, quite high in the initial 24-48 hours. But as things settle down, we'll have to use our discretion and make sure that we space out these investigations and plan investigations depending on the patient's requirement. But some common lab investigations from the hematology point of view, we just discussed about hemoglobin ranges that we accept. Anything above 7 to 8 is acceptable, provided the ECMO is running well. Sometimes we aim for higher hemoglobin targets, especially on VV ECMO, if we are not able to get good saturations, because we want to maintain adequate oxygenation to the tissues. Platelets in the initial phase, we target anything above 75 to 1 lakh. Same thing in the bleeding patient. But as things settle down, we can accept lower platelet values if there is no bleeding concerns. And ACT is monitored with a target ACT of anywhere between 180 to 200 or 220 if you are having additional things in the circuit like, CRRT and other things where, you might need a little higher anticoagulation. And take PT, APTT coagulation parameters, all those were discussed. Electrolytes and other organ functions, we want to maintain electrolytes in the normal ranges because, these children are, extremely sick. They're dependent on technology. We don't want anything to go wrong with their cardiac functions. Especially, ionized calcium, potassium, magnesium, all these things need to be closely monitored, and periodic monitoring of liver and renal functions, like I mentioned. Blood gas, we've already discussed. Monitoring for hemolysis, look for any change in the urine color. Plasma-free hemoglobin, not freely available, but if you have it, please do it periodically. Other indirect evidences would be elevation of indirect bilirubin, elevated LDH, and low haptoglobulin levels. These will tell us about the ongoing hemolysis. Now, sepsis can be very difficult to recognize at an early phase because they are all in thermoneutral environment, especially with the ECMO flows. The temperatures are very well controlled, and fever is not a usual response that you see. And a lot of things which may look like sepsis may be because of so many other reasons, like high white cell count and other things. So it's important to have a very high index of suspicion in these patients. Subtle things like, if they're needing more fluids on that particular day to maintain good flows, that gives you a small indication that there may be a capillary leak happening, and that could be secondary to sepsis. New onset tachycardia, which you can't explain, unexplained drop in platelets, all these things should make one suspect that, this patient may be septic. Of course, we do monitor white cell count more than a single value. We have to go by the trends of these, values, white cell count, CRP, procal, and blood cultures need to be drawn. Sometimes as surveillance cultures, because we don't want to miss out on a bacteremic sepsis in these patients. The other sources of infection could be the lungs. They could develop ventilator-associated pneumonia. It could be a catheter-associated UTI, or it could be a central line-associated infection. Mediastinitis is, one possibility when you have especially central cannulation in these patients. Echo is very, very useful. It tells us about cannula position adequacy. It tells us about adequate cardiac functions, especially on VV ECMO. We worried about right heart functions because the lungs are bad and they can have significant pulmonary hypertension. With central cannulation, you can monitor for pericardial effusion. So that's why echo is very, very important. During VA ECMO, it tells us about recovering cardiac functions. It also tells us about stunned myocardium and how whether we need to be draining the ventricle by putting drains. Role of chest X-ray we've already discussed. I will come to circuit monitoring. Physical monitoring of the circuit is important. You have to check to make sure the sutures are adequately in place. As time goes on, these sutures may loosen out. So you don't want to have an accidental decannulation in these patients at any cost. So make sure that there is no bleeding at the cannula site. There is no signs of infection. So periodically, the dressing needs to be opened with sterile precautions, making sure that everything is neat and dry. You have to inspect the circuit physically with a torch to look for any obvious clots and see if your anticoagulation needs to be, titrated to make sure that there is no increase in these. So this is about checking the circuit. Then you have to look at the RPM and flow that has to be noted on a daily basis periodically. You have to make a note of, for this RPM, how much flow you are getting as a baseline. So remember, the RPM is not the only thing that decides flow in a patient. There are other things, preload of the patient, the cannula size, the circuit position, and also the afterload of the patient. All these things come into factor that decides the flow for that particular RPM. So for the same RPM, if your flow increases, then it could be because your preload is better or your afterload has reduced. But for the same RPM, if your flow has reduced, that means, there is some problem. It could be hypovolemia, or it could be increased afterload. The patient may be moving, coughing, he may be hypertensive. So all these things can be understood by looking at the RPM and the flow. There are a few pressures that we closely monitor. The first one is the pre-pump pressure, which is called the P1 pressure. It is, you're looking at, in the picture, you can make out exactly where it is monitored. It is before the pump. It actually monitors how much negative pressure is required for the pump to be sucking the blood out of the venous cannula. And because it is negative pressure, the range is anywhere between -20 to -70. Extremely high negative pressure tells us about a couple of things. One, it could be related to the patient's volume status. Patient could be hypovolemic, or it could be related to the cannula size, cannula position, or there could be kinks in the circuit, or it could be that the patient's leg is positioned in a different way from before. So all these things, it gives us information about how the flow is happening. There are units where it's not possible to monitor these pressures, though the only way to make out that there is a problem with the drainage is chattering the circuit, but that's usually late. And that is one way of, for the same reasons, the chattering in the circuit can happen. And the pressures, these numbers are shown in the monitor. I've indicated in the circle how the numbers are shown in the monitor. The next pressure is the P2 or the pre-oxygenator pressure. So this is post-pump and pre-oxygenator. This records the post-pump pressure because pressures from now on will be positive pressure because the pump is actually pushing blood into the oxygenator. So this is usually positive, can get up to 350 to 400. And factors affecting this pressure can be pump speed and distal resistance. So if your oxygenator resistance is high or the patient's afterload is high, then you will see that these pressures can go up. So this baseline, when you start ECMO in a control setting, you'll have to monitor and make a note of what was this pressure to begin with, and then trend the pressure over a period of time rather than looking at fixed numbers. Then there is a post-membrane pressure, which is a P3 pressure. This is after the oxygenator and before the blood drains into the patient. This is also a positive pressure, and it depends upon the pump flow. It also depends upon the oxygenator resistance and what is the distal resistance in the circuit, including the systemic vascular resistance in the patient. So all these things can affect your post-membrane pressure. Now there's one more pressure, which is called the delta pressure, the difference between the P2 and the P3. So what is the difference in the pressure between the pre-oxygenator and the post-oxygenator? That pressure is very, very important. It gives you an idea about how your oxygenator is functioning. So if your oxygenator is developing clots or there is increased resistance for some reason in the oxygenator, this delta pressure will actually reduce. So rising delta pressures more than 2 times the baseline, you have to look at whether there is a problem with the oxygenator, needs a change in the oxygenator. So take home message. Remember, ECMO is a life-saving, it's a complicated process and things can go wrong. And as it's you have to assume that things can go wrong when a patient is on ECMO, and look at preventing these problems. And the best way to prevent them is monitor these things closely and address these things in a very proactive way. Safety protocols need to be strictly followed, and monitoring diligently is very, very important. Monitor the patient and circuit, both of them closely. Lab investigations frequently need to be done in early stages and later can be spaced out. And imaging, most of the time, you'll have to use bedside technology as much as possible because of the challenges that are involved in moving the patient who is already on ECMO. So remember this, it is hours and hours of boredom. And if something goes wrong, it is terror. So prevention is better than cure. Thank you very much.
Thank you, Shiv. Any questions? So Dr. Shiv has taken you through to everything, and Murphy's law Murphy can be very strong here. So if things have to go wrong, they will go wrong, and you have to be prepared. And a lot of voice monitoring you can see in the workstations. Any questions, feel free to ask. Dr. Pranay, good evening, sir.
Yeah, good evening, madam. Good evening.
Nice
Sorry, I
to
couldn't
see you.
attend yesterday. I was busy.
Nice to see you,
Sir,
sir. Sir, anything that you want to share? It's always so nice to have you, and look forward to seeing you on the 12th.
Yeah, sure.
Anybody wants to ask any questions? Otherwise, we will move to the next talk. Dr. Amish. Amish, you're here. Thank you, Shiv.
Yeah, I'm here.
You want to start screen sharing?
Yeah, if
You're a co-host, right?
yeah, okay.
Yeah, you are a
starting to
co-host.
share.
You can share. Yeah. Yes.
Okay, you can see my screen.
Yeah, I can see, but there's so much to read. Dr. Amish. So Dr. Amish is pediatric ICU consultant. He was ECMO head, and in fact, you are not able to come for the workshop. Otherwise, you would have been the national coordinator as well for Pedicriticon ECMO workshop, right, Dr. Amish?
Yeah, I have to go for a friend's daughter's wedding.
Yeah. Okay. Dr. Amish will be talking about weaning and decannulation, both in adults as well as in pediatrics. Over to you, Dr. Amish.
Hi, good evening. Good evening, Indira, for this beautiful workshop. And together with Dr. Pranay and Ravi and all. I'm sure it's going to be excellent. I'm going to miss this workshop, but as you can see that, all of us really love doing ECMO. And the best part about this ECMO is why I've kept this slide is you can see that when we were training back in early 200, to be an ECMO consultant, you have to be a pediatric intensivist, which is a 3-year training. And during our time, there were no pediatric intensivists who used to come from pediatric background or from NICU background. So I did NICU and then I went to PICU in Australia and later in UK. Most of the pediatric intensivists would come from either ENT or anesthesia or cardiology with pediatric cardiology background or pediatric nephrology. So it was very rarely a neonatologist or somebody from pediatric can go to PICU directly. So now with the pediatric intensive care chapter, you all are lucky that you can do PICU straight away after doing your pediatric training. And also you can do 1 or 2 years. And then you can see after 3 years of PICU, we needed to do 2 years of ECMO training. And now with the ECMO Society of India, you all are lucky that straight after PICU, you can just do 1 year of pediatric ECMO training. And I feel that anybody in today's day and age, all intensivists should do ECMO training because it's the future. Okay. And this is what I've been believing in since 1999 when I saw my first ECMO patients in NICU fellowship. And I've been in love with it for the last 24, 25 years. I said the same thing in 2015 that pediatric ECMO will come with the big bang. Nobody believed me when in 2015 I came to India. And 10 years down, we are the highest number of ECMO in the world. Already the adults are outshining us, though neonates and pediatricians were the first one to do pediatric ECMO. So I feel that it's something you all should definitely take up. And it's something where you all, those who are really interested in intensive care, should do the ECMO training program, which is by the ECMO Society of India. With that, I'll start going to my talk. Okay, so I've been told to talk about trial of or weaning. I like to say more of trial of than weaning. Weaning, I feel that it's more like, people get confused with ventilation. So I think that trial of coming off ECMO is more of a trial of, and then the second part will be of decannulation. So let's take the first part of trial of. So question one should think about, just one sec. Yeah. What are the risks of continuing ECMO? Okay. Every day when the patient goes on ECMO, you need to know next day, what are the risks? Do I need to keep on going on ECMO or should I thinking of coming off? Okay. What are the measures on which I want to come off? What are the ventilator settings patients are requiring? And what degree of support I'm ready to accept? So whenever we think that the patient is ready, we need to know what exactly is the patient's requirement currently and what will happen when I come off. And you have to have your mark that when the ventilator or plateau pressure goes above 15 or plateau pressure goes above 30, sorry, if the FIO requirement goes above 60, if my inotrope requirement goes above 0.1 or 0.15 of adre or noradrenaline, I will consider as a marker that my trial of is not working. It's always good to have that marker before you start weaning. So everybody's in sync that if this happens, the trial of has failed, we'll go back and revisit the thing. So we should have that parameters in our mind, and it's a standardized parameter which you should be going for. So we ECMO trial off. Okay, so when do we trial off is to make sure that the respiratory and cardiac function have begun to improve. Do we wait till they are fully 100%? No. We often like to say like ventilator, when they are better, we wean them and extubate them. Same way in ECMO, once they are better, you require very less ventilator support or very less inotropy support. Your parameters, as rightly discussed in the last time, all looks good. Then you should be thinking of whether I can come off. While coming off before, you make sure that on VE ECMO, your flows are low. On VV ECMO, your sweeps have begun to fall. Okay. As described in the previous lecture, X-ray has to be improved. Echocardiography in VE ECMO has to be good. And eventually your gases or minimal flows are good. Most important, as we heard in the very first lecture, you should have a good fluid balance. You do not want to come off having a high fluid balance on the patient. okay, or positive fluid balance when the patient is going on. So now you see this patient, okay? So this is a young 22-year-old man having a nice beer. We are celebrating his birthday. We take him to a garden and we give him a piece of pizza and he's enjoying all that. You think, oh my God, he looks so good. And then I bet he must be trialing off. Sad to say, after 6 months of waiting for lung transplant, he was not getting lung transplant. His wish after 6 months of being on ECMO was, I had enough. I want to wean too. I want to come off ECMO. And it's a one-way trial off for palliative care. So when you're trialing off, you need to have that idea whether you're trialing off for bridge to ventilation, bridge to transplant, bridge to mechanical support, bridge to palliative care. Okay, so you need to take off. I'm not going to talk about bridge to transplant or bridge to mechanical support or bridge to palliative care. That's a different thing. We at ourselves are going to restrict to bridge to ventilation or bridge to extubation. So it's a recovery from ECMO we're going to talk about. Okay, so this is which is about 90-95% of the time we are talking about bridge to trial off to ventilator. Okay, so let's go to that. Let's talk about the easy one first, VV ECMO. We know venous ECMO, we said that. In venous ECMO, we usually do not worry about the flows. Okay, you can keep the flows as it is. The most important thing is your gas flow, which is called as your sweep gas. So you will see that as the patient is improving, you would have lowered your sweep gas, okay? And when it's ready, you would also decrease your ECMO FiO2. At the same time, you would have increased the patient's ventilator requirement, which is needed. Once you think your patient is ready, you see what is the patient's own respiratory rate. He's not tachypneic. Look at his peak inspiratory pressure or your pressure plateau pressure. Okay, look at your delta P. Make sure your PEP is not very high. Usually we say that PEP of 5 to 8 is good. Your delta P of 10 to 12 is good. Your respiratory rate based on age is about 20 to 25 is good. Okay, but don't only look at the respiratory part. It's very important that all the organ perfusion, your CNS, your cardiac, your renal, everything is better. While VV ECMO, look at the CVP, make sure it's low, do a point of ultrasound, make sure your right-sided echo is looking good. Obviously, you'll be monitoring your ABG. You want to make sure that the child is not in sepsis, your infective and your organ perfusions are all normal. So as we rightly said in the previous lecture, to monitor those things. And once everything is normal, you think the child is optimal or the adult is optimal, you need to come off the ECMO. So ECMO, meaning of VV ECMO is balancing between your natural lung and your membrane lung. When your natural lung is bad, your ECMO is gone out. As soon as the child is improving or the adult is improving, you come down on the membrane lung, you let the natural lung do its own work. Once you think the patient is ready, you decrease your lung flow, your ECMO flow, and allow the natural lung to do itself. There are various methods to do that. Most of the time, we just do the simple method by coming down on the sweep gas. Okay. Rarely, as in Stockholm, Scandinavia, they say that they introduce CO2 to see if the natural lung can wash out the CO2. They call it as a CO2 challenge test. It's something new they are doing, but we don't worry about that. For me, important thing is the lung is doing a normal CO2 elimination. The lung is maintaining oxygenation when the sweep gas is nearly off, and the compliance. I think compliance of the lung is very good, about 0.5 ml per cc per kg compliance, and it's more than that, then it's excellent. And so that's what we need to monitor when we are trying to see if the patient is coming off VV ECMO. So now we are looking at this beautiful flow chart. Okay, we have initiated VV ECMO. We know why we have initiated. Only in the beginning we know when we start somebody on ECMO, we have decided that it's ECMO to recovery. Okay, so we are going to talk about ECMO to recovery. And the patient has started recovering. You can see the improvement in the patient's condition. Okay. Once the patient conditions are improving, you start decreasing your flow. It's a continuous process. It's a daily process. Okay. Then you target your ventilator settings. You look at the patient and look at the ventilator. Your FiO2 will be on your rest settings of 30. Your PEEP will be about 6 to 8. Your tidal volume will improve. Initially, when you put on ECMO, your tidal volume will be about 2 ml per kg. And when you see that the patient's tidal volume are increasing to 4 to 5 ml per kg on a low peak pressure or low plateau pressure, you will think that the patient is improving. Okay. As soon as you think that the patient is improving, you can do a temporary check where you can come off the sweep gas. Daily in the morning, once I feel the patient is improving, I come off the sweep gas, remove the sweep gas, increase the FiO2, okay, to 40 to 60%. Make sure keep peak pressures of 6 to 8 ml per kg and see if the child is maintaining saturation. Okay. So this is what you can do as a daily weaning trial of. As we could say in extubation or weaning ventilation, we can do that spontaneous breathing trial or CPAP pressure support trial. How we do with that? Do it for 20-30 minutes. And before that, you realize what is happening. If the patient is really tolerating, you know that you need to optimize everything in the next 24-48 hours and officially come off ECMO. Okay. So when you're coming off ECMO, usually you can do the same thing as we'll go in detail in the next step. We can decrease the sweep gas. In pediatrics, we can often come off the sweep gas, or we can decrease it to 0.5 liters per minute or lower. In adults, we just come down below 1 liter per minute, and then we wait and see. For VA ECMO, obviously your lung is not an issue, so you need a good lung compliance. You just need a minimal inotropic support. Okay, little bit of low dose adrenaline 0.02 to 0.05, little bit of melanin of 0.2 to 0.5, rarely NORAD of 0.1. Okay, if you are planning to come off while the time of coming off. Most of the times when we are on VECMO in newborns and pediatrics, we come off the inotropes. Except for milrinone or antihypertensive measures, there are no vasopressors or inotropes given. So they're usually quite good. We make sure that the blood gases are maintained on minimal flow and minimum sweep gas. Most of the time in pediatrics, it's important to look at the PA pressures, okay, to look at the right ventricular side and make sure that the PA pressures are nearly half systemic. You maintain good cardiac output. As we rightly said, your mixed mineral saturations are good. Anywhere between about 75 is excellent, provided everything is normal. You look at the about 65 to 75, you might accept it. What I find really good is increased pulsatility. 20 to 40 difference between the systolic, diastolic based on the age, and good pulsatility of the arterial line makes me feel most confident that the patient is better. You do a point of care ultrasound. There are a lot of measures we can do in newborns and pediatrics. We often say that the ejection fraction is good, more than 30 to 40. We are happy. In adult, they look at the TAPSE, they look at the LVOT and the flow through that, and they look at the ejection fraction, and they sometimes even accept 25 to 40, but they might come off with intra-arterial balloon pump, or we often come off with intra-arterial balloon pump, or with some minor support. But that's what you see. But ideally, it's best in newborn pediatrics if the ejection fraction is more than 40. If it's post-cardiac, you want to make sure there's no residual defect. Okay. And everything looks good. So let's now, as we said that in VA ECMO, we often look at the hemodynamic stability. Often we say that in adults is the flow of less than 3 liters per minute, sweep gas of less than 3 liters per minute. Okay. We usually try to come down to 2 to 1 liters per minute. Good pulsatility, we said. Good mean arterial pressure in adult is about 60. Okay, and low dose inotrope of this. Stable cardiac rhythm, stable metabolic state, looking at the lactate and the mixed venous, and do a proper functional echo to look at the parameters which they do, especially in adult patients. What are the minimum flows? I like them. Okay. In neonates, I say 50 to 80 ml per kg is 75 ml per kg per minute is good. In adults, 3 liters, less than 3 liters, you are starting to wean off. By the time I'm ready to come off, I want to aim them at 1 liter per minute on my VA ECMO. Okay. So you can see that in neonates from 100 ml per kg, we're just coming down to half. But in adult, from 4 to 5 liters per minute, we're coming down to 1 liter per minute. Okay. At that time, it's a minimal flow when you can see that and give them trial of coming off ECMO. Okay. In VA ECMO, often what we should do, how in In VV ECMO, we increase the ventilator and see what the patient is doing. And daily, we try to see that if we clamp the ECMO circuit, what is the patient doing? Same thing, we can do that in VA ECMO. In my morning rounds, I would just clamp both the circuits and see what the pulsatility is doing. What is my patient doing? Do I think the heart has recovered? Do I see? And I just get a feel for the patient when you're next to the patient's bedside. It's very important to be next to the patient's bedside when you think that the patient is about to get weaned off or patient is ready to come off ECMO. Okay, there's nothing better than looking at all the numbers, but getting a feel for the patient, looking at the patient's conditions, looking at the monitor itself, and then using your investigations, your blood gases, your lactate, your mixed venous sets, your echocardiography, your end organ perfusion to guide and support what your gut feeling is. Okay. So this is a planned weaning. Okay. Planned weaning where we are weaning to recovery. Sometimes it can happen in exceptional situation. Exceptional situations, as we said, it's a bleeding. Okay, if you suddenly start getting in neonates and intraventricular hemorrhage grade 2, 3 or 4, you start having intracerebral hemorrhage in adults. Most often what we find is that sometimes they start oozing and bleeding really from mouth and nose. Okay, that usually happens when people some new nurse, bedside nurse starts suctioning the patient on heparin on high pressures. Suddenly the mucosa in the mouth or nose tests, and they are very notorious to control. And it's my nightmare over the last 20 years of doing ECMO when I have to control them. Sadly, every 2-3 years, I get one case like this where we have to come off because of excessive bleeding. Luckily, with the newer centrifugal pump, we do not see the GIT bleed as much of the stomach, duodenum, and large ball as we used to see with the centrifugal pump in the old days. Same thing, rupture of the circuit and rupture of the circuits. Rupture of the circuit used to happen more commonly with the old centrifugal pump, but with the newer circuits, we don't see that. Obviously, sometimes we can see disconnection of any part. And believe me, people laugh at it and think, oh my God, how can any parts can get disconnected? Something when you do for so many years, you have seen. I've seen internal jugular cannula coming off. I've seen in central the aortic cannula coming off, and things can go wrong. As Indira before said about the Murphy's Law, things can happen. But the idea is, as an intensivist, we don't panic, we save them. All the time, wherever I've seen the cannulas coming off, something leaking or rupturing, luckily, none of those patients have ever died. You control everything, everything works properly. Okay, so this is what had happens sometimes where you can have a bleeding, things can go wrong, there's a massive clot or accidental decannulation happens. Then you might need to plan to come off suddenly, or do you want to go back on ECMO? So those are the exceptional where you go in emergency, come off to recovery. For VA ECMO, as we said, that like everything has a flow chart and a graph, you can have this beautiful flow chart and the graph, which is available easily online in all the articles, in all the ELSO guidelines. It's all is given exactly what cardiac parameters, what pulmonary parameters, what renal liver functions, what end organ perfusion you should be going, how you should be coming down on the flow curve down to 2, 3, 1 liter, and how you should decide if your goals are met, then come off. If your goals are not met, then you might need to go back on ECMO and find out why your goals are not met. So these are the goals. I don't want to go into specific numbers because I feel that all of you, when you do ECMO, you can read that and it's easily available. The important thing is to be aware, what are you looking at? Okay. As we explain again, usually we look at the bridge to recovery. We do not look at bridge of other interventions or bridge for transplant or bridge for palliative care. Okay. Most important, whenever, as soon as I feel that as soon as my patient is on ECMO, my chance to look for opportunity to start weaning. As soon as patient goes on ECMO, within 20 minutes, you can start coming down on your vasoactive drugs. Okay, especially your vasoconstrictor like noradrenaline should be first drug should come off within 2 to 4 hours. Usually on good ECMO, they should come off. Your inotropy can be taking a little bit of time, and your inodilators are usually good to keep it on. Okay, look for that window. Same thing, as soon as the patient is on my VV ECMO, I try to reduce the ventilator support. You do not want, usually when you go on ECMO, they're on massive delta P, they're on a massive plateau pressure with PEEP of 10 to 12 and oxygenation of 100%. So you want to start weaning them down as soon as you go on ECMO. So be aggressive. Looking for the opportunity to start weaning as soon as you go on ECMO and get them down to your rest settings. Okay, get your FiO2 down to less than 60%. Get your peak pressures down from 12 and 10 to 8 slowly. Okay, get your rates down from 25 to slowly down to 20, 15, and 10. Okay, then get your plateau pressures down to 20 or 22, whatever you feel is ideal number. But get the ventilation down, and VECMO get the inotropy down. So look for the window of opportunity to wean everything. Do not, once they go on ECMO, say, my job is over, I'll see the patient tomorrow morning. No, that 12 hours, 6 hours you have wasted. At the same time, after 24, 48 hours on VECMO, think whether you can start coming off. Okay, within 2 to 3 days, VECMOs, people can come off ECMO. 5 days maximum, I feel that we should be thinking of not coming off ECMO for VECMO. Rarely for cardiac patients or neonates or adult with severe disability, they take a little bit longer. 80% of VECMOs, 5 to 7 days, they usually come off if the underlying cardiac condition should recover by then. With VECMO, neonates, I love them. PPHN, meconium, 48 to 72 hours. If given a choice, I would put all PPHN and meconium on ECMO instead of putting on high frequency and nitric and struggling for 2 weeks. Put them on ECMO, within 24, 48 hours, pH pressure come down by 3 to 5 days, they come off. Okay, another 48 hours, they get extubated and they are all fine. Okay, so neonates come off fast. Your ARDS in infants, 7 to 10 days. Start weaning, start seeing if they can come off. The shorter the distance, the shorter the time when the patient was ventilated pre-ECMO, the faster they can be weaned off. If patient had only 2 to 3 days of high pressure ventilation or 2 to 3 days of invasive ventilation, twice that time, 6 to 7 days, you should come off. If patient had 5 to 7 days, 10 to 14 days, you should come off. More than 2 weeks, you're asking for trouble. It's going to take more than 4 to 6 weeks. You're looking at prolonged ECMO. Okay, that's why we think that after 10 to 14 days, putting on ECMO in a low in a low resource country like India, one should consider what we are doing. Not that patients do not come off, patients come off, but you should be aware and counseling that they're going to take longer. Obviously, we'll hear more about it in the next lecture. So now let's come off. Now we are going to plan to trial off. Now, before you trial off, it's always good to finish all your invasive work before. Once you trial off, when the patient is looking stable, you don't want to then precipitate or agitate the patients to do invasive procedure like putting new central line or putting new, we talk about renal replacement, putting a new vascular. You need to put a new arterial line, put it before. You want to change your tubes, do that. And do the things which you need to do. Dot your I's, cross your T's, and make sure everything is stable before you start your trial off. Okay. Once you want to trial off, you make sure that you commence your ventilation. For VECMO, I feel the most easiest is when I'm doing daily. I do not like to wean too much. I just remove the green tubing for oxygenation. I just remove the sweep gas. Remove the sweep gas, keep the patients on high flow, 100 ml per kg or about 3 to 5 liters. Don't worry about the flow. Okay, so they do not. And put the patient on the ventilator. Put the patient on the ventilator, which I think is obvious the patient will tolerate. And do blood gases every 20 minutes for 1 to 2 hours and get a feel whether the patient is tolerating. Titrate my ventilation for 2 hours. If the patient is fine, stabilize them on the ventilator gases. Give a short trial of 4 to 6 hours. If patient is good, I would go for decannulation. This is usually for patients who have had a short run of ECMO about less than 10 days or 7 to 10 days. For those patients who have more than 10 to 14 days, usually you keep them off the sweep gas. I usually keep them off for 12 or 24 hours and then come them off, give them a prolonged trial off. Okay, very easy to do for VECMO, and that's why I feel that it's very easy to just come off the sweep gas. Second thing is slow weaning. Okay, slow weaning is that you reduce the FiO2 of ECMO by 10% every 15-20 minutes For those who have been on long-term run, come down slowly down on your FiO2. Sometimes we even stop weaning for 6 to 12 hours and try again the next day. At the same time, obviously your sweep gas you're monitoring with your flow. You start reducing your sweep gas, get it down to 2 to 1 liters, and then see what the PCO2 is doing. Do the arterial gases after each increment weaning and make sure the child is fine. Continue to wean slowly over 24-48 hours and get the FiO2 down to 21%. So the membrane lung is flow is good. Blood flow remains the same. Come down on your sweep gas in adults to down to 1 liter, in your pediatrics down to 0.5 and liters per minute, and then see what the patient is doing. This is a slow process of weaning. Whether you go for slow or you go for green off, removing them, the thing is both works. You find what works for you or your unit and go for that. And you see what you feel clinically, what the patient is doing. Okay. 80 to 90% of the time, I just go with the fast method because I've been training them every day and I find that they work. Slow weaning, I often use for my prolonged ECMOs, which are more than 3 to 4 weeks. And that's what you do that. Trial off periods for those long periods, we keep it for 24 hours. Minimum trial off, I do about 2 to 4 hours. Okay. If the gases are poor, you feel that the patient is not responding, you just connect the green pipe again. ECMO flows are good. You decrease your ventilator settings, keep the child on moderate flows, and repeat the trial of after further 24 hours, correcting what is correctable. What are the usual indication why you can ECMO flows, the ECMO trial of fail is? One is water poisoning. In ICU, especially in adults, water poisoning is very common. The ECMO has been, ARDS management is taught to adult intensivists from our neonates and pediatrics. Baby lung ventilation by Wong, about 2 to 4 ml per kg, we taught the adult patients. Permissive hypercapnia, permissive hypocapnia from Chicago, came from neonates. In 1985, we taught the adult cardiologists, adult intensivists. Water poisoning. The pediatric cardiologist showed the world that restricting fluids on corporeal circuits, restricting the fluids in ICU, positive fluid balance is associated with mortality, came from pediatric cardiac, which we showed to the adult one. ARDS management, whatever people say, whatever the adult intensivists say, we can proudly say that we neonate and pediatric intensivists showed you to the world. In fact, so much was that thing that for 18 years, our center in UK, the Glanfield, the biggest center in the world, was managed by pediatric intensivists who are neonatal pediatric trained. Adult intensivists were not allowed to touch ECMO patients. The ECMO consultants and we were not happy with intensivists because they had no clue what they were doing. Okay, so we 5 adult ECMO intensivists were all from pediatric background, doing ECMO from newborn to adults for nearly 15 years. When we decided the adult intensivists after the H1N1 started getting better, we trained the adult intensivists from Cambridge, Guy's and Thomas's and Manchester and all. And that's how the things showed. So it's very important that ECMO was something which was made by neonates, which was later made in pediatrics, and the adults came in last. But sadly in India, the adults are using more ECMO than pediatrics and newborns. Sorry for the digression. Let's go back to the weaning. So we go that, so weaning, and now for something only slightly different. So we talked about VV ECMO, now we talk about VA ECMO. Okay, so the VA ECMO, like we did preparation for VV ECMO, we do the same preparations, put the new central lines, arterial lines, make sure the patient is stable and organs are fine, ventilations are fine, echocardiography is fine, everything is fine. Once you are ready to come out, okay, in VA ECMO, you need to decrease your heparin in such a way that if you're going to use bridge, okay, whenever we often in newborns and pediatrics use a bridge, then we put half the dose to the circuit and half the dose to patients. In olden days, and sometimes we used to keep a lot of drugs on the circuit. Nowadays, we don't put anything on the circuit. So all the drugs are always on the patient. And you ventilate the patient as we did for VV trial off. Okay, it's the same parameters. Now, if you are using a circuit, now if you are using a bridge between your artery and vein, okay, so you need to remember when you need to every 5 minutes have clamp on, clamp off, every 20 minutes, sorry. Okay, in that, when you clamp off the arterial circuit first, you clamp the bridge, and you clamp off the venous circuit. So the patient gets the flow, the cannulas get the flow, so the cannulas do not clot. Okay. When we are going back on ECMO, oops, sorry, my mistake. I've written it wrong over here. To clamp on, when we are clamping on, we clamp the artery first, we release the bridge, and we clamp the venous first. Next. Okay, so the bridge gets circulated through the bridge, and the patient is fully working on its own. When we need to go back on ECMO, the drainage cannula, the venous cannula is opened up, the bridge is clamped, and the artery cannula is opened up. So the patient is back on ECMO, and the ECMO cannulas get flow. Okay. So this is what we do every 10 to 20 minutes to make sure that the cannula gets flushed. In that 20 minutes, we see what the patient is doing. Is the patient maintaining the blood pressure? Is the pulsatile pressure is fine? Is the patient's heart rate not going up? And we monitor the patients before we clamp on again. We'll make sure that the patient, before we go back on ECMO, we do a blood gas and make sure that the lactate is maintaining itself. The trial on ECMO is usually about 2 to 6 hours. Okay, sometimes in adults, in bigger patients, we try to decrease the flow. As we said, that we come down to flows about 1 liter in adults. Okay, about 50 ml per kg in neonates to this. Once we are ready to come down on the flow, we also can decrease up to 0.5 liters per minute. Once we come down, we make sure that the mean arterial pressure is again maintained. We make sure that the pulsatility is present. Okay, if needed, we do the TOE or echocardiography to make sure everything looks good. Once everything is looking good, then we increase the flow back and then decide whether they're going to come off. Either they're going to come off in the bedside, or are they going to come off and decannulate it in the OT or the cath lab. Okay, so that's how we do in VA ECMO. VA ECMO is slightly more prolonged, where you can decide between the bridge and a low flow and deciding about when to decannulate. There are all the flow charts which you should follow, and that will help you exactly what to be doing. Decannulation. Decannulation, the slides, most of the slides have Chris Harvey, who was my fellow. Now he's a director at Leicester. And these are the few slides which he had taken and he shared with me, and his pictures. I've been using it. So once you have good guesses of ECMO, the patient is cardiovascularly stable, your surgeons are happy for VA ECMO, okay, then you need to assemble your team to come off the ECMO. Whenever we are coming off ECMO, usually I like to sedate and paralyze the patients, because you're removing the big cannulas from the groin and the neck. So usually I like to just use ketamine and intracurium. Okay, patient is always on analgesia, morphine or fentanyl, and you do your normal gown and glove, and then you can try and come off. For decannulation, we usually clean the skin. And remember to clean the part of the cannula as well. We use the chlorhexidine and betadine. Go through the cycle of using the betadine, wait for 30 seconds, clean your betadine, put your chlorhexidine, wait for 30 seconds, and then clean it. Make sure, as when we physicians decannulate, especially venous ECMO, we should be sure that we keep our green area draped properly, as you are doing for a surgery, as you're doing for insertion. Sometimes what has started happening is people started taking shortcuts, put a small central line drape, and then they try to come off. Okay, that's a bad practice. Okay, because that's where you might introduce infections and you might have issues. Once you try to remove the cannulas, you need to keep a pressure. And often people used to just do pressure closer in the past. I, from beginning since 2008, always take a horizontal mattress sutures, which Mr. Richard Furman, the father of ECMO in Europe, has shown us. Always take a horizontal mattress sutures around the cannula. Don't take a purse string. It will just puncture the things up. So as I'll show you the pictures about how it looks like. So take your suture ready, cut all the sutures which are there, you clamp off the circuit. The assistant will clamp the cannula as close to the skin as possible. Okay. The assistant will pull the cannulas and the surgeon will do the mattress sutures. That was the case in the past. The surgeons used to do it. Nowadays, we pull it ourselves. But like surgeons have assistant surgeons, while you are doing that, you should have your junior intensivist or your other consultant colleague helping you. So they are pulling the cannula and you concentrate on putting your mattress and you concentrate on closing your suture line. So this is your cannula over here. As you can see, this is a beautiful cannula in an adult, and you can see that it's taken. Then you take your mattress sutures. Okay, it's just one mattress suture from one. It's just one mattress sutures from year to year, and back and tying it up. Okay, so this is what you do, and it just happens the straight way. Okay, and so that's what you do it. What you don't do it is take a circle sutures. Okay, then the whole skin gets puckered. In newborns, it leaves, and in pediatrics, it scars the whole tissue. And as the child grows, this area becomes a big blob on the hand, on the neck, or in the on the femoral, and it looks very dirty, and it leaves a very bad scarring mark. So it's never good to do a whole circular suturing. Okay. After decannulation, often people ask me, do you want to send the tip for cannula for culture? Never do that. Okay. The cannula on the way will scrape your skin, will grow anything. In spite of everybody cleaning, it'll grow something or the other. Second thing is, people have the habit of putting a betadine dressing or a chlorhexidine. Not needed. Once you've cleaned everything, keep a dry dressing. Why dry dressing? If it starts oozing or bleeding, you can see it immediately. Okay. If betadine is there, it'll take a long time for the blood to come out. Okay. Once you remove one cannula, you do the other cannula. What important to remember is that in India, most of the time patients are on antibiotic. So make sure that the antibiotic which patient is on or given is coming off those antibiotic. Give a dose before. Often we try to see if the patients are not on any antibiotic. We just give a dose of Vanc and Gent in our centers. In your centers, do whatever you feel is comfortable and do accordingly. After decannulation, successful trial of, okay, for VE-ECMO, after the successful trial of, you need to go back either to theater or decide with the surgeons if they're going to do it in the bedsides. So obviously the surgeons will do that. They will identify what they are going to do, and usually they remove the arterial cannula first. Most of the times in neonates, they might not repair it, but nowadays the surgeons are not tying it off anymore, and most of the cardiac surgeons and the plastic surgeons will repair the carotid artery. In adults and in older children, definitely they have to repair the artery. Okay. And once the artery is repaired and tied the area, then they remove and tie off the vein. Okay. Most neurological insults happen from ligation of vein than the artery. This is something which we often see on follow-up. Okay. So this is what it's important to see, that we make sure that this is happening. Also, what's important to remember is that before the patient, after 3 to 5 days, make sure you Doppler your vessels which have been tied off, especially in VE-ECMO, and Doppler them before they get discharged. And obviously my colleague will take it more about how you should look at them in long term. Post decannulation, obviously a chest X-ray is mandatory. Check all your parameters. If it was on vascat, do not consider vascat now. I would always put it before. One thing we often see is that sometimes they have inflammatory or hyperpyrexia. Okay, the ECMO circuit was very good to maintaining the temperature, but once you remove that, you have a temperature hyperpyrexia. Don't miss that always for fever. It's just inflammatory changes will settle down in 24-48 hours. Pre-organ damage. If the patient's organ damage have had acute kidney injury, pre-ECMO, you will have issues post-ECMO. So you remember that if you are on CRT before coming off, put your vascat and you need CRT. So this is a graph which exactly shows that. So in summary, VV trial off and decannulation is simple. Increase flow just prior to trial off. Set your ventilator. Keep your sweep gas off. Check your ABC. Long trial off is possible. Decannulation is not a surgical procedure, and intensivists can do it themselves. VA trial of is a little bit more complex. You need to see in your, when we do the stations, how we can do the bridging, how we do clamp on, clamp off. Don't make the mistake. I just made the mistake just now while explaining to you how to do it. It looks complicated when you give a lecture, but when you start doing it, it's very systematically, and your hands-on is always the best way to do it. Your trial off is shorter. You can't do 24 hours trial off. Okay, circuit is clamped off. Make sure the heparinize the patient is continued. Okay, flush the cannula every 10 minutes if you are doing the bridging. Prepare, once you are ready, prepare the surgeons and make sure they do the proper decannulation in the theater or in the bedside. We talk about ECMO. This is my first mobile ECMO in 2008. Even in India, people are doing a lot of mobile ECMO, especially from Hyderabad, especially from Chennai. And obviously, Dr. Pravan is, Dr. Oja is doing an international transport as well on mobile ECMO. So mobile ECMO is available and something to see. And this is just a picture to show you that. Okay. With that, that is weaning and decannulation made simple. Hope you understood. If any questions, I'm happy to take that. Thank you. If you still have issues, feel free to email me or to WhatsApp me. With that, I'll end that. And if there's any questions, I'll take it.
Thank you so much. Thank you so much. And please stay. You have to be here for the group pic.
Sure, sure.
Any questions? We have just one more talk, but can you all think your videos, not your audios? We will take screenshots. Dr. Pranay is there. Let's not screen share. We'll just take the photos and then after that. Anyway, there's a trial screen share, so it's working. We can stop screen sharing, yeah. And everybody open the videos. So Bala, where's Bala?
Yes, ma'am.
You'll be taking the screenshots? Or should
Yes,
I?
ma'am.
You'll take? Yeah. So you'll have to take the different frames, no? Some more videos have to be opened. Nice to see everybody. Some more. Dr. Shankar, Pushpu, Bala, yours, Devika. Some more. Devika, who's this? I think, and everybody please smile. Cheese. Okay. How do you go to the next frame? Yeah.
Just now I'm taking.
That's it.
Ma'am, 1 minute.
Okay. Our cheeks are
Second
pale.
group.
That's it. Thank you. I think I've also taken some pics.
Thank you.
Oh, thank you. Thank you, Amish. Look forward to seeing you in the conference. And over to Dr. Shankit. So just the long-term outcomes. We have cannulated, we have decannulated, and we're going to see the long-term outcomes. Dr. Sanket is a consultant at the SRC PICU and cardiac ICU at SRC Children's Hospital, Mumbai. He was at Apollo with us before he went and trained in UK. Over to you, Dr. Sanket.
Hi. So, am I audible?
Yes, yes, and slides are visible. Yeah.
Hi everybody. We had a stream of talks today. I'm last in the sequence. We had a varied sequence about day-to-day running of ECMO, its complications, cannulation strategies, and weaning. So the last talk in this event stream is long-term effects of ECMO. So about ECMO, you have already heard all. So you know the principles and on what ECMO is based, types of and indications for a veno-arterial and VV ECMO. And as we know, ECMO serves as a bridge to transplant or recovery and act as a rescue option for life-threatening conditions. Survival, so usually VV having a better survival rate compares to VA ECMO because of the complications. So 42% for VA ECMO and 59% for VV ECMO. So why study long-term outcomes? So when we say long-term outcomes, it's usually more than 6 months follow-up and see how the patient progresses after they are weaned off ECMO. And ECMO per se have prolonged recovery challenges. They endure extended recovery periods, often experiencing range of physical, cognitive, and mental health difficulties. Studying long-term outcomes can help us in better resource utilization and with a primary goal to enhance post-ECMO strategies, ensuring better recovery pathways for the patient. And eventually, the most important thing, it is patient and family education, setting their expectations, giving them a brief idea about what can happen post they are weaned off ECMO so that they are also prepared mentally. So survival rates, we have already discussed 30 days, 5-year survival rates. So 46%, 30 days and 33% at 5 years, whilst for a VV ECMO, they are slightly more, being 48% and 36% respectively. The long-term survival factors being dependent on comorbidities, any complications while patients being on ECMO, and the previous health condition and the reason the patient being on ECMO. Now, when we say long-term outcomes, most of the studies have divided them into three divisions: functional impairment, neuropsychiatric, and neurocognitive. So when we say functional impairment, these have been found to be highest in post-ECMO follow-ups for adult patients. So approximately 52% of the ECMO survivors were reported to experience long-term functional limitation affecting their quality of life. And these were in terms of activities of daily living, reduced strength and mobility, experiencing fatigue and exercise intolerance. When the clinical data was compared between VV and VA ECMO, there wasn't much difference in terms of functional impairments. In terms of cognitive and neurocognitive impairments, like memory impairment, attention deficits, reduced problem-solving abilities, approximately 38% had a prevalence in the studies in adult population facing significant cognitive impairment post-recovery, indicating a widespread issue. The risk factors for them being prolonged ECMO duration, existing neurological injuries, acute brain injury while the patients are on ECMO, especially on VA ECMO, which could lead to these outcomes. In terms of neuropsychiatric sequelae, patient exhibit significant mental health issues post-ECMO in long-term follow-ups in adult patient, with 36% experiencing anxiety, 31% facing depression, 18% diagnosed with PTSD. Additionally, 37% reported sleep disturbances, highlighting the psychological impact of critical illness. Again, the contributing factors being delirium, sedation, critical illness neuropathy, which can lead to these outcomes. In terms of clinical observation, the clinical studies indicated that patients on VV ECMO experiences higher rate of PTSD compared to those on VA ECMO. Now, when we looked at those studies, they could not find any particular reason why VV ECMO patients should have more of these outcomes. But few of the explanations being prolonged, the VV ECMO being on a longer duration, the patient requiring longer ICU stay. So probably these could be the reason. Secondarily, some functional impairments in terms of post-cannulation complications. Now, in terms of quality of life, when it was tried to assess how is the quality of life post ECMO in adult population, multiple scales were used, and what it was found was individual exhibiting low, significantly lower scores in terms of quality of life compared to those with general population. The instruments used were multiple, like SF36, SF12, having those numbers of questionnaire, EQ5D, which is European Quality of Life 5-dimensional assessment, and pediatric quality of life inventory. So these are few of the instruments which were used for assessments in different studies. And what they found that many individuals reported limited physical activities contributing to lower scores. In terms of physical versus emotional, the physical quality of life outcomes were poorer compared to the emotional ones. And a common finding among population was persistent fatigue, significantly impacting daily functioning and overall well-being. We could not find much of a pediatric studies looking at pediatric outcome. However, I came across a very nice study done in Canada, versus in a single ventricle physiologies undergoing Norwood, and a comparison was made between Norwood requiring ECMO versus children does not requiring the same. And what it was found in pediatric outcomes, there was not much difference in terms of functional, neuropsychiatric, or neurocognitive outcomes. So, however, they reported lower perceived physical appearance score compared to the peers. 25% of pediatric patients who survived ECMO showed mild developmental delay, and long-term pediatric survivor often experienced impaired social functioning, which can affect their quality of life and integration with the peer groups. Simultaneously, caregiver stress plays a significant role in recovery process of the pediatric patients, highlighting the importance of support system for the families. Now, when we say about predictors of poor outcomes, we know that longer the ECMO duration, like more than 7 days, there are increased risk of complications and worse long-term outcomes. Acute brain injury or neurological complications during ECMO again contributes to decline in recovery potential. Any severe pre-existing illness prior to ECMO initiation more likely to encounter difficulties in achieving favorable outcomes. And again, the patient who is going on ECMO per se. So if the patient is really sick at the initiation of ECMO, it will have a poorer outcome. So higher peak lactate levels observed during ECMO were linked to lower 30-day survival rates, indicating a critical marker. Then when we saw the difference between V and VV ECMO outcomes, there were more frequent complications like kidney failure, neurological injury was found in V ECMO, and the physical impairment was also more compared to a VV ECMO, which had a better recovery of physical and functional abilities and few neurological complications. The reason which we all know, lungs being acting as a filter, less of neurological insult in VV ECMO, less require of anticoagulation in VV ECMO. So they had better neurological outcomes. Also, however, what it was found that VV ECMO had worse neuropsychiatric outcomes. The reason which we the reason of which we discussed maybe could be prolonged hospital stay and critical illness issues and or the longer use of sedations. Now, rehabilitation strategies focus on improving mobility, strength, endurance through tailored exercises, physiotherapy, especially for patients suffering from ICU-acquired weakness. in terms of cognitive and emotional support, neurocognitive rehabilitation alongside counseling services to address common issues such as anxiety, depression, PTSD. And again, follow-up care ensures regular checkups and assessment to monitor the patient's quality of life and functional recovery, facilitating ongoing support and adjustments as needed. So even though we go through all the articles, there aren't still much articles looking at long-term outcomes. And most of these articles have been using multiple scale. The population is heterogeneous, hence lacks standardization. So lack of standardization is one of the research challenges, and the other is more existing studies focusing primarily on short-term recovery outcomes, whereas the prolonged or long-term follow-ups have not been done in much of the studies. And again, we need pediatric studies also. So what is the use of all these studies or outcome assessments? It will help to establish a long-term care pathway post-ECMO, ensuring structured follow-up and routine assessment to identify functional and neurocognitive impairments early. Multidisciplinary team integration like cardiologist, neurologist, physiotherapist, and psychologist to address the diverse need of ECMO patient holistically, and eventually a patient-centric approach, implemented individualized rehabilitation plans that cater to each patient's unique circumstances, promoting better recovery and quality of life. In conclusion, ECMO saves lives but have a significant long-term impacts. Survivors require tailored physical, cognitive, and emotional rehabilitation. And definitely, we need more studies for better understanding, and follow-up care are critical for improving outcomes. Thank you.
Thank you so much, Sanket. That was lovely. Your slides are beautiful.
Thank you.
So even though, I mean, we are seeing the negative aspects and the fine, but so many lives are saved, and even our follow-up, I think, especially with pediatrics, because the comorbidities are much lesser, they rally around both neurologically as well as, other functionally as well. This is from our follow-up.
I think follow-up is really important, like, to know how outcomes are and how they actually do later, which most of the centers lack. We don't do enough.
True. Want to stop screen sharing? Dr. Vasant is here. There, Vasant.
Hi, ma'am.
We missed a screenshot, a pic with you. You've come back. So for the last time, before we all say good night, could you just, all of you, open your videos for Vasant's sake? Otherwise, the Rajinikanth and Kamal Hassan guy will get very upset. Thank you all for humoring Vasant. You went to cannulate an ECMO patient? I mean, put an ECMO?
Oh, ma'am, we have got a call. Probably you'll be getting that patient, ma'am. So,
For ECMO?
yeah. Yes, ma'am.
Okay. So Khushbu, Deepkala, Shinu, you want to open your videos? Cynthia, Bala, you're not there in any pic. I'll take the screenshot. Deepkala, okay. Here goes. Everybody's, Cynthia, Bala, Shinu. All ready? Everybody smile. Vasant, you're seen. Yeah. Take it. Thank you. Good night, everybody. And see you on 12th in person. Thank you all faculty. Bye.
Thank you, ma'am.
Thank you very much,
Bye,
ma'am.
Shiv. Bye, Sanket.
Hi, Chief.
Thank you.
Hey, who's this? Oh, Vasant, your daughter.
Vasant's daughter. So sweet. So sweet.
We should have taken her also in the picture.
I know. The youngest delegate. Youngest delegate.
Hey, what's your name?
Huh?
Mm.
Ah.
Okay,
Show
see
me
you
your
guys.
face.
Bye.
Bye,
Thank
Sumit.
you, Bala, for the support
Bye,
from,
ma'am.
from Rela. Bye.
Bye.